Yeah, okay. Well, welcome everybody to this meeting of the Integrated Care Board for the North East and North Cumbria, 28th of January 2025. I'm Liam Donaldson, the chair of the board. Welcome to the members of the public who are attending. And we've just got one apology for absence, which is one of our partner members, Lisa Taylor. We have a number of declarations of interest. We'll make those mainly as the agenda items arise, but just to note that we will have to pause at the beginning of each of those items for quite an extensive reading, which Deb, our board secretary, will do. Are we quorate? The minutes of the previous board meeting held on the 26th of November 2024, are they an accurate record? Anybody spot anything inaccurate in them? No. Okay, thank you. And then the action log and matters arising of matters we did discuss at the last meeting and are being followed up by the executive team. Are there any where you wanted to inquire about progress? Thank you. So we turn now to... Oh, it's Claire. Yes, please.
Just to pick up on number 61, Chairman, that relates to infection control campaign. We have been discussing this with the communications network across the region. A further meeting was held on Friday, and we are developing a more detailed campaign which aligns to some learning that from a number of years ago, based on an evidence-based link to infection control, working with the nurses as well.
Thank you. On now to our Chief Executive's report, Sir Sam Allen.
Thank you very much, Salim, and good morning, everybody. So it's been, about 8 weeks since we last met, and we have been through an incredibly busy time across NHS services, and just in terms of particularly the sort of the peaks over the Christmas and New Year period that I'm sure many colleagues will be familiar with in terms of the respiratory issues that perhaps they've experienced, family members have experienced, but the demand on our emergency departments and in our hospital services has been really significant during that period, and indeed was widely reported upon nationally, with a number of critical incidents being declared in other parts of England during that period. I can share, Chair, that during that period within the North East, North Cumbria, we did not reach the point where we needed to declare a critical incident at any particular point in time here, given those pressures. But I would say it was extremely demanding, and there were certainly some days, hours, evenings where we certainly came close to that, particularly given the level of demand being placed on hospital services, the occupancy in hospital, and indeed the respiratory issues that were so prevalent in the general public, indeed being also experienced by our own staff as well, and affecting workforce availability. I do just want to commend all of our colleagues across our NHS services, but also all of our partner organisations, community and voluntary sector, and indeed all the unpaid carers out there. I think when we are facing periods of time when the services are under significant duress, it really is a whole system effort which pulls us through. And I do want to say a particular mention to all of the operational managers and leaders who work in our emergency planning and resilience services, who provide cover 24/7 across the system, and through our strategic coordination centre we're providing hourly updates, hourly reviews of particularly the demand on services, and indeed the spirit across all of those services in the mutual aid. There were certainly some parts of our system that experienced some very significant pressure that they've certainly only got through that through the mutual aid of other parts of the region coming to their support. So I think, Chair, it's important to acknowledge that. Alongside that, I do want to highlight the decision we took as part of our urgent and emergency care plan to establish acute respiratory hubs. The board will be aware that we had these in place last year, and whilst we didn't get any additional resources to fund new urgent care demands, we did take the decision at risk to stand up all of the acute respiratory hubs. By the 9th of January, they had seen 9,000 people. These are 9,000 people that would have ordinarily been seen in general practice or presented at the emergency department, and 98% of the capacity, the additional capacity for respiratory needs that we commissioned had been utilised. And we have also taken the decision to extend the funding for the acute respiratory hubs to the end of February, particularly to meet that need. Now, having said that, you'll see in my report that there's an update on vaccinations, and vaccinations for COVID, for flu, for RSV, whilst this past year we had the largest network of providers to vaccinate, we have not performed as well as we usually do. Now, of course, comparatively, we are a good performer when you look across England, but we do know that we really can't be complacent when it comes to vaccinations. We need to make sure that we're reaching every part of our community, and given our immediate look back over the last 8 weeks, the pressure on services, looking at the pattern of flu and respiratory illness, we will be doing further work to prepare our vaccination campaign for the year ahead, Chair, because I think that's going to be really important. I think one of the things we do pick up is I think apathy and complacency are very strong words, but I think certainly the vigilance around vaccinations, getting them early, indeed when all of the pressures on services and increased national communications on the importance of vaccination, we did see a sort of a surge in people wanting their vaccinations, but we need to ensure that we're vaccinating people earlier. We need to ensure that we're getting the vaccine to as many of our workforce that need it, and also in good time. So there's certainly more that we can do over forthcoming months to prepare for that. Chair, today on our agenda, later on our agenda, we'll be receiving an update on the system that we've put in place across services, particularly around quality and safety when it comes to urgent and emergency care. There's been some national publications, I think probably one of the ones that sticks in my mind, particularly given it's a very challenging read, is from the Royal College of Nursing, particularly around the use of what's called corridor care. And this is typically seen when the level of need is such that there aren't available beds or bed bays in hospitals, and it results in people being cared for in spaces which wouldn't ordinarily be used for corridor care. Now, that is not something that we support or condone here in the North East North Cumbria, yet in reality, at times of pressure and extremis on services, it does happen. But one of the things that we want to do is to make sure that we've got a really strong system in place whereby there are incidents, there are issues, there are quality concerns, that we're picking them up in real time. I think the other example of that perhaps also would be around our mental health urgent emergency care pathways, and really working to ensure that we've got patients receiving the right care in the right place as well. So I look forward to that presentation later today from members of our quality team who are here to demonstrate how we've been working, I think at the Secretary of State's request, which was very clear that getting through winter was about making sure that we were doing that safely, and that we also had an eye on quality, and that's certainly what we've worked hard to do, Chair. So just a few other things I just want to update the board upon. So the 10-year plan for health, which is a national exercise at the moment of engaging the public, but also people working in services on a future 10-year plan for health. And I say health and not the NHS. It's about all of health, which obviously everybody's got a stake in. And what the Secretary of State's talking about with his 3 key shifts, whether that's from sickness to prevention, hospital to community, and analogue to digital. We've been doing some further engagement work here in the North East North Cumbria, and we'll be holding our own workshop on this shortly, but also anticipating the real focus around neighbourhood health. We've established a Living and Ageing Well partnership, and we really think this is going to be a key strategic vehicle for us in terms of how we approach neighbourhood health and how we particularly focus on what is out of hospital care and more community-based care, working with what's known as integrated neighbourhood teams. Now, the really good news is we're not starting from scratch on this. There are lots of examples right across the North East North Cumbria of integrated neighbourhood teams. They're just all called something slightly different, and that's okay because they've been designed mainly in places, whether it's in Cumbria or in Durham, even where we are today. But nonetheless, taking a look across the region, thinking about what are the core design principles of an integrated neighbourhood team, how do we ensure that we are making progress to that, and in doing so also resourcing this adequately and really thinking through if we're going to really develop and expand community and more neighbourhood services, how we shift both the resource but also the way in which people access services and the way people are thinking about how to access services. In an ideal world, we want to keep hospital, more specialist-based services there and accessible for the more specialist critical pathways. But health is something that people live with every day. It's about having good housing, it's about having meaningful occupation, it's about having good social support networks. So what does a good integrated neighbourhood health team look like? So I'm really delighted that Levi's leading that, and Levi, perhaps in a moment you can say a couple of words on that. Chair, my report also brings back an update on the assurance work that we've undertaken working with our 2 mental health trusts on assertive outreach and intensive community teams. And the board will recall this was a piece of work that's been undertaken nationally, particularly following the very tragic incident in Nottingham, the Valdo Calcane incident in Nottingham. And you'll see in the report that we've got a plan in place in terms of working with the 2 mental health providers to provide assurance around the services in the North East and North Cumbria that are available, particularly for people who are more challenging to engage in services and require a more assertive approach, and also individuals who require follow-up and more multi-agency working as well. Chair, my report also provides an update on a range of collaboration and partnership working across the region. So firstly, how we're developing, well, in fact, our provider collaborative and our NHS trusts are developing alliances and groups across the region. Why are they doing this? Well, we've got 11 NHS organisations in the North East and North Cumbria, and given a whole range of reasons, whether it's workforce needs, whether it's utilising assets that they have, there really isn't any one part of our system that can exist on their own as a single entity in a sustainable way. So we've got our group in Tees that's developed and is probably the most progressed. We have an alliance, the Great North Alliance, which involves 4 of our trusts in the north, and our 2 trusts in the centre of the patch, County Durham and Sunderland South Tyneside, have prioritised 5 pathways to work together. So this isn't driven purely by resources, but resources are a factor here. We only have a finite set of resources, and it's important that we use those in the most efficient and effective way possible. but this is predominantly driven around improving outcomes for our residents underpinning these. And I'm sure, Chair, this will be an area the board will be interested in terms of how it develops and also the benefits it realises as well. Collaborations with our local authorities continues, and we have regular meetings with our Director of Adult Social Care and Director of Children's Services and work programmes with them. And indeed, more recently, over the last year, we've been forging closer relationships with our combined authorities, two in the North East, and potentially, should they be successful with their devolution bid, possibly a new one in Cumbria as well. And particularly the role of combined authorities, and indeed the white paper on devolution will set out and describes potentially bigger roles with their convening powers, but particularly their role around economic development, workforce and skills, really important partnerships. And delighted that our Health and Growth Accelerator, where we've secured £18 million for the North East, North Cumbria, which will target specifically supporting people to maintain their employment through interventions we're working very closely with our combined authorities on. And then just finally, Chair, I do just want to give an update on the real living wage. The board will recall that we had Baroness Armstrong, who chaired the North East Child Poverty Commission, come and present to us at the back end of last year. And indeed, one of the recommendations in that the Child Poverty Commission made was that the real living wage should be in place across services, and if it was in place across NHS services, that would make a real difference and help address the issue of child poverty. We are the biggest employer in the region, and if we think about the NHS pound and how far that goes, it is important that we play our part in there. So I just want to share with the board that reviewing this position, not only as the ICB, which we committed to be a real living wage employer, but right across all of our NHS trusts. And I hope as we conclude the planning round this year, this is something we will be able to confirm. Chair, had a fantastic visit to Silverdale General Practice. I have to say it was absolutely brilliant. Why did I go there? Because this is one of several practices across our region that scored extremely well in the national patient experience feedback. And I have to say, having spent a couple of hours in that practice, it was really clear to see why. All of the colleagues I met, right through from colleagues on reception to nurses to GPs, right throughout the practice, they live in their community, they have their community at the heart. They operated as a team, and you could sort of really feel the positivity in that general practice, and it really made me think, my goodness, I wish this could be a practice I could be a part of. Of course, whenever you visit, you go on a visit like this, you think about how we're sharing this learning across, and it did make me think about using our learning and improvement community as a way of which we can both highlight and share the really positive work underway in general practice. And I want to thank the colleagues for the time that they gave me that day on that visit. Thank you.
Thank you very much, Sam. Questions and comments for the Chief Executive? John Rush.
It's just a comment really, Sam, and it's linking it into sort of the overall governance process for the committee that I chair in terms of finance, performance and investment. I noticed the entry regarding the System Recovery Board, and that you're looking on a quarterly basis at the cost improvement plans. So I'll just need to sort of create a link from FPIC to that process, because that's part, obviously, as well as some of the things that we've got to do. So I'll look into that and make sure that those connections are utilising the same information, hopefully, rather than duplicating anything. That's the idea.
I think that'd be really, really helpful, John, because we're definitely not seeking to replicate the FPIC, the Financial and Investment Committee's role, but it's more about sort of how we track this through the Recovery Board, but that would be great.
Okay, thank you.
Thank you. Levi Buckley.
Thank you, Chair. Perhaps just to expand a little bit on some of points Sam raised around neighbourhood health. I think we should note the terms left shift, neighbourhood health, out of hospital community, used fairly interchangeably. As Sam said, we're really using the banner of living and ageing well within the North East. The basis for that is the work we've been undertaking with partners has really identified probably 3 key areas for us to focus on. And one of those will be frailty. So when we particularly look at our older population, although frailty can apply at several different ages, we know from an anticipatory and proactive care and comorbidities of that population, it's probably the area where we can make the greatest impact in quality of life, early intervention to keep people living and functioning independently at home or whatever their community setting is, and also then reduce the need for secondary services, which tend to be more intense use of resources and often are treating rather than preventing. So we've been doing quite a lot of system work with general practice, with our voluntary community sector and with our foundation trust partners. We hope to have our vision for the North East and North Cumbria clarified towards the end of March, and a proposal will bring that back to a future board meeting. The tricky bit here, as our Chief Executive alluded to, is how we will look to resource this over the coming year. We did have Secretary of State for Health joined us in Carlisle and Whitehaven early January, continued to espouse the government's intention to move more and more care out of hospital, which is encouraging, but we still need to think through the logistical approaches to that. Secondly, we'll be looking at respiratory services. Again, as people have heard from the Chief Executive's report, our acute respiratory hubs have had a great impact. How can we more embed that within core business rather than something that we switch on through winter and periods of peak activity? And then thirdly, a very clear focus from partners to look at children and young people. We reflected on our approach to Best Start in Life, which is a very shared ambition with our local authority colleagues. And we know that there's still a lot more we can be doing to make sure we're providing the best start in life for children, maximise those opportunities, and that really gets into some of the inequalities work we want to focus on. So feeling very optimistic for the future, but it will be a challenging pathway ahead.
Thank you, Levi. Christopher Kersbelcher.
Thank you, Chair. Just a couple of items, really. The first was on the NHS Change 10-year plan, and I know it talks about the regional event, but from a Health Watch Network point of view, with the help of the ICB, we actually run in 14 workshops across every place across North East and North Cumbria, and also holding workshops with some of the seldom heard groups, such as children and young people, ethnic minority groups, and learning disability and autism, and then a further report will come back to the ICB to complement the work that's being done at that event, the regional one on the 10th of February. The other item I want to mention was the seasonal vaccinations, purely because some of the feedback that's coming in from communities is this year there's a lot more misinformation across social media, telling people not to get vaccinated. That seems to be going unchallenged, and perhaps we need to have a revisit of the comms around that, and that's something that the network perhaps can help with, and whether or not we need a fact checker or myth buster in order to get the vaccinations increased next year.
Chair, if I may, that would be incredibly helpful, and I think, Christopher, we should think about whether or not we should do some really specific work with Health Watch and your support to go out and sort of listen and get all of these issues out on the table as well, because just something shifted, and I think it's too sweeping a statement to say this is because people don't want it anymore. And I think we know, because we hear about it every day, the impact of social media, whether it's influencers or what people are hearing, and the misinformation out there will be driving and affecting potentially some people's behaviour. And I think we're going to need to think a bit differently about how we get the right information out there to everybody. And we may need to dip our toe into using social media even more, and potentially looking at how we develop our own sort of health creators or influencers, because some of the more traditional messages, we do that. We do paid social media as part of our targeted campaigns, but I think we need to keep evolving this.
Thank you. Rajesh Nadkarni.
Thank you, Sam. Really good news that we got the Health Growth Accelerator, so it's absolutely fantastic to maintain people in work. Also positive that we're working with the combined authorities. The question I had was, I believe one of them has also got some focus of money looking at young people. Are we in conversations about what we could do further in that area? Because many of the younger people, their needs probably maintaining in work are more to do with mental health or with learning difficulties or being on the autism spectrum. And what is an ICS we could do further rather than just focusing on physical health, which is not exclusively the issue in this particular funding, but that would be the focus, I understand, with this growth accelerator.
Yes, and we're putting together the implementation plan at the moment for the Health Growth Accelerator. I think we'll target specific groups in that. For example, women will be another area we'll look at. We'll also look at young people, and we'll also target specific areas depending on levels of deprivation as well, Rajesh. So I think there's probably a lot more we can do together with the combined authority on young people, and it's fantastic that Claire represents us on the Skills Advisory Board, which is one of the key work streams into one of the combined authorities, and we're, as I said, we're in discussion with the other areas. I think there's also something for us, and Kelly I know has got experience in this around career pathways into health and how we both pull the need and the resources that we've got in a combined way to target economic growth, job creation, and how we use our assets as an anchor in the system to provide those jobs for young people. So it's both the support, providing the jobs, but the more we can do this together, the more impact I think we can have for our population, and that's why the partnership's so crucial.
Thank you very much. Tom Hall.
Yeah, thanks, Chair. First thing I'd say is noticing how much overlap there is between many of these items. My question was going to be around the Living and Aging Well partnership and neighbourhood health, but actually when you talk about the Health and Growth Accelerator, when you talk about the alliance arrangements across trusts and thinking about community services, how much these things really do overlap, and we need to keep considering that as a board in terms of making sure that we're not duplicating or indeed missing opportunities. I guess the Living and Aging Well work sounds really exciting. I was just wondering whether there'd been consideration around multiple disadvantage, multiple complex needs as one of those priority areas as well. I'm sure you can bring that back when we bring the more in-depth discussion, but it feels like another opportunity for working more collaboratively with the combined authority and indeed local authority partners on an area of key concern.
Yeah, just to reassure you, Tom, absolutely quite a deep dive into a lot of data sets, looking at both deprivation and inequality. So I think one of the challenges we will face as a system over the year ahead is what's our willingness to target our resources at the areas where there is the greatest deprivation and hence the greatest opportunity to narrow that health gap. And that will look at how we may need to shift resources around the system. So absolutely, I'm happy to discuss that further with you outside the meeting.
John Pearce.
Thank you, Chair. I just wanted to reflect some of the really positive developments around partnership working and some of the work we're doing across children's services in terms of complex care that's referenced in the report. And I think there's a huge opportunity there. So when we talk about integration, when we talk about integrated neighbourhood teams, I think it's fair to say that across the country, children's services are probably quite a long way behind other parts of the sector system in terms of how we move to those much more integrated approaches, and that gives us a real opportunity. And I think if we look at some of the national children's reforms that are coming through the the Children's Wellbeing Bill that's going through Parliament at the moment. That provides a real platform for us to start to really accelerate the way in which we deliver integrated services for children across those key priorities: best start in life, children's mental health. And I have to say it's really great in so many people have spoken and have mentioned children and young people and have referenced that. So, you know, I think there's a real positive momentum now in terms of how we take that forward, and the sort of model of family health that's proposed within the National Children's Services reforms gives a really good platform to start to apply some of those integrated neighbourhood team principles into children's services as well, and just really keen that we don't lose that opportunity.
Thank you, John. Neil O'Brien.
Yeah, this kind of links to a lot of things that we've discussed, and I'm really interested in the vaccinational work as well, and how we can improve our approach there. But just to inform the board that we are planning an engagement exercise with general practice, getting out, going to talking to as many frontline clinicians, practice staff, to hear from them what the pressures are within general practice, and try and bring that back in a structured way to inform our strategic plan for general practice in the years to come. It really links with the neighbourhood health model, but I just thought it was important to raise, and we'll bring the output of that back probably in the late spring, summertime.
Thank you. That's, I think, taken all the comments. So thank you for the presentation, Sam, and also for the discussion, and very helpful to be able to drill down in detail in some of those things and look at their implications. The next two items are going to be presented by Claire Riley, Chief Corporate Services Officer, starting with the Board Assurance Framework, Q3.
Thank you, Chair. People will be more than familiar with this report. It is a regular report that we bring to board. This shares the Q3 position, and attached in the appendix is the Board Assurance Framework and also the Corporate Risk Register, which highlights those risks scoring 12 or above. There are some risk movements that are detailed within the report. You can see capital spend, ICB running costs and medicines team capacity. Their risks have been reduced below 12, therefore they will be removed from the register. However, there has been some new corporate risks included, which link to EDI, dental, weight loss injections, pharmacy collective action and high rates of suspected suicide. I'm happy to answer any questions, Chairman, but I hope the board can approve this paper.
Mike Smith.
Thanks, Claire. The report's nice and clear as always. I guess I'd taken the opportunity at the start of the year to reflect back on the start of last year to see how we're moving. And in essence, the targets have actually got a bit steeper and the progress is about the same. We're possibly slightly worse on some targets, slightly better on others. But what we're not seeing over the course of the years is a trajectory that shows that we're moving towards our targets. I guess my question is, what can we do to turn that around?
Yeah, I think that's something that we can take into the committee infrastructure, if I'm honest, Mike. So I think the more detailed conversations need to happen within the committee and with the exec lead based on those risks as well. We do see movement, we do see risks moving off the register, we do see risks coming back on, dependent on the circumstances that we're dealing with. I think there's a broader conversation to be had with board probably a board development around risk appetite. I know that we did this about a year or so ago, and I think bringing that back into board and having that conversation would be really helpful, and a more detailed conversation about some of the high risks that we are living with.
David Stout.
Yeah, I mean, I think we need to think about offline about the value of targets and whether these targets are actually aspirational but not achievable. And if that is the case, then what is the benefit of actually replicating them and having the obvious questions that are being raised? However, if they are achievable, then what is the plan to actually achieve them? So I think there is a little bit of deep thought outside that we need to have around targets.
Thank you. Yes, we'll absolutely do that. I think that conversation in a development session would be beneficial as well. Yeah.
Okay, Claire, what are you asking for from the board on this one?
To approve, please, Chairman.
Okay, is everybody happy to agree? Thank you. Moving on then to the governance handbook.
Yep, again, people will be familiar with this handbook. There has been some minor changes that are detailed in the front sheet, as well as material changes that are again detailed within the front sheet. Just to make a bit of an amendment that isn't in the document at the moment, there is an error saying that the financial delegations linked to FPIC, where in fact they link to exec committee. These will be changed in the future edition. Happy to answer any questions, Chair.
Okay, everybody happy to agree with that as well? Thank you very much. Moving on then to the committees. So this is an opportunity for each of the chairs of the committee to highlight the key areas of business that they've covered in their discussion. So we're going to start with the Executive Committee, which is chaired by the Chief Executive, Sam Allen.
Yeah, thank you, Chair. So the papers include minutes of our meeting on the 12th of November and the 10th of December, where you can see that we covered a significant amount of business. Just a couple of things to update on. Received a really good update on targeted lung health checks, and actually it's been really fantastic to see the results that are being achieved through targeted lung health checks, and I think particularly the 537 lung cancers being found and diagnosed and followed up, which I think is just excellent. And as a committee, we've received updates from the Cancer Alliance on this over a period of time, and in fact we've committed ourselves to go further and faster in the North East, North Cumbria, because we know we've got some big opportunities here if we are going to get and catch cancers much earlier. And of course, the earlier we get a cancer diagnosed, the more successful the treatment is for individuals. I've mentioned already, Chair, the Health and Growth Accelerator, and at the committee we received the delivery plan on how we're going to utilise the funding, and work continues on that. And we also had an update on dental access recovery. I also do just want to mention that the committee did a sort of a more deeper review of the Healthier and Fairer programme, which is one of the key programmes in the ICS, and absolutely key to delivering our integrated care strategy. And we're joined by Siobhan Brown, the programme director, and Amanda Healy, who is Director of Public Health of Durham, who jointly leads that piece of work. Members of the board will recall that we've committed funding for this programme over a 3-year period, and the programme has developed plans to utilise that. The one area we did just note at the end is given the financial position nationally and also locally, that we will review the investment in Healthier and Fairer as part of our investment plan that we'll bring to board as part of our annual plan this year. But it was good to note the progress they're making in that programme, and particularly on outcomes such as smoking and alcohol. Chair, thank you.
Thanks, Sam. Just a little caveat on the excellent performance on the lung health checks, that it's important to keep a very clear view on our work on reducing cigarette smoking and tobacco, because there can't be a false leap of logic that people come to believe that they can carry on smoking and their cancer will be cured. First of all, lung cancer is still has a relatively poor outcome even when treated compared to others, though we should diagnose it as early as we can. But tobacco also causes 6 other lung cancers, heart disease, stroke, and a long list of other illnesses. So important to keep good performance on that in focus, but also in context. Other comments and questions? Thank you. We move on to Sir Pally Hungin, the Chair of the Quality and Safety Committee.
Thank you very much, Chair. A few points to bring to your attention and to the attention of colleagues. Much of what I'm going to discuss has actually been, I'm delighted to say, has been covered by others so far. One of the points that one needed to note was that the vaccination rates, particularly for influenza and obviously COVID, have been very low nationally. But what is particularly concerning is that within the National Health Service, different staff members, different groups appear to have differing rates of vaccination uptake. And as was reported in the BMJ 2 weeks ago, there's particular concern amongst nursing staff nationally where vaccination rates for flu have been under 50%. Now, I suspect that this position resonates with many other trusts up and down the country, but many other ICBs and ICSs up and down the country. And I'd like to reinforce the suggestion earlier that we either consider doing some specific work through our public health colleagues, plus or some kind of action plan to raise these rates throughout our area. I think that's of some importance. Secondly, in line with what you said earlier, Sam, we would like to reinforce our thought that our staff have worked diligently and extremely hard in the last 2 or 3 months, particularly in the last month, in terms of dealing with high rates of illness coming in through A&E and other areas, and not least in general practice. And I think it's our role as the Quality Committee to commend our staff, to recognize how well they've performed through very challenging circumstances. I do have some very good news, though, because I've just seen the latest data on flu rates and hospital admissions, and these have dropped from 13.5 per 100,000 to 7.5 per 100,000 in the last week. So that's a substantial drop, and I do hope that that will be seen within our area as well to ease pressure on people. And you've already mentioned urgent and emergency care and the pressure upon staff, and I don't have exact data on whether or not people are being treated in corridors, in accident and emergency departments, or as inpatients. That's a question I might want to ask to see if there is if there are any data available there. I also just want to cover the area around Martha's Rule to say that this is being rolled out in our locality, an extremely important development for the NHS, whereby people can get second opinions if they are not completely happy with what's going on in any particular situation. And I think we're pretty much at the forefront of rolling this out in our locality. Something that isn't mentioned, 2 quick items. One, that we did discuss at our committee, individual areas, pockets of not necessarily deprivation, but possibly other cultural groups, for example, travelers or people of different ethnicities, and that in certain specific groups there are a myriad of complexities which might make it difficult for people to access care, not just language difficulties, but also an understanding and appreciation of how the systems work. The point here being that whereas we are concerned with our overall rates of disease and how well people do in terms of morbidity and mortality, unless we can focus in specifically on areas where these are of particular concern, I don't think that we will be able to improve our overall figures. So the committee is going to continue discussing which specific sectors of our population need additional input, so to speak. And I think that that is an area which we should pursue in a very targeted manner. And finally, not on the slide, and I might ask our chair to comment on that, that we have launched, as was mentioned, the Patient Safety Centre for our ICS. This is currently embedded within the organization, but work is being done to refine how it might be set up and established. And the Quality Committee understands that by March we may have a paper indicating how the organization of the Patient Safety Centre might proceed. So that's all I need to say at the moment. Thank you.
Thank you. Sarah. Thank you, Chair. Thank you, Sir Pally. Very comprehensive report as usual. I just wanted to chip on the conversations we have been having about vaccinations, because we know that the most basic prevention steps that the NHS provides is vaccination and screening, and yet we struggle to kind of lift the figures for both for various reasons. And I know that we're doing some work on working with our population to address this, but obviously I know Sir Pally and the Quality and Safety Committee, we have had discussions on how we can extrapolate this conversation to involve our staff. With the staff uptake of vaccines being low, obviously that has put pressure on providers to deliver that quality gold standard care that we all strive to in the ICB, but it's also about changing perceptions. And whilst we can do a lot of communication, I think that needs to start with our staff. If we can get our staff to engage and increase vaccination and screening rates, we will be able to extrapolate that into the community. So basically, I guess what I'm saying is that, you know, I'd be interested in learning of all the different pieces of work that we're doing with our public and with our staff as well, in order to improve our rates for the coming years.
Mike Smith.
On a similar topic, really, that less than 50% of staff being vaccinated in certain staff groups is a pretty shocking figure. I appreciate that for staff members, perhaps their perception of the risk.
That is a national figure.
There's a national figure. Yeah, no, I appreciate that. I imagine for staff members, they may perceive that their personal risk is perhaps lower than some patient groups, in that they may be well people on a day-to-day basis. But as Ira explains, obviously the impact of them being unwell is magnified by them not being able to look after others. I also recognise that obviously staff members live in the same world that patients do, and they're exposed to the same social media influences and things, albeit one might expect them to have a higher level of medical knowledge. One would hope they would, given that they work in the NHS. I wonder whether that research, Pally, that you described would be helpful to bring back to board to try and understand why staff members aren't engaging with vaccinations.
If I may answer that quickly, it's my personal belief that this kind of research needs to be done at place, so to speak. So I think that we should conduct work in our locality, in our ICS, ICB area locality, to find out why rates have been low. I think rather than trying to commission some kind of national work, which I'm sure will be done elsewhere anyway, we need to concentrate on ourselves and see what we can do as a result to try to improve rates. And I certainly think that's an important.
Well, your committee is generating a lot of interest, so we have other interventions. Neil O'Brien.
Yeah, there's been quite a lot of mention of vaccination rates. I just want to say that the overall performance for vaccine uptake in the North East and North Cumbria still stands in the top, certainly the top quartile in the country. There is definitely problems with healthcare worker vaccination. What I might suggest is, maybe for a future board, is when this current season is fully over, it's still not fully over, then we can bring back some comparative data for this year versus previous years, maybe update the board on some of the engagement activity that we are doing. There's been a lot of behavioural insights work done as well that might be of value for you all to hear. So it's just a suggestion that we could bring that back to a future board when this season is over, if that would be helpful.
Yeah, I mean, I think on the COVID, it's not really surprising, because all the external signals, you don't need to test yourself anymore, you don't need to, you know, you can carry on as normal, it's, people are then bound to start perceiving it as a less serious disease, but as you know, it still kills people and takes people into hospital and needing intensive care, amongst other things. Yeah. Thank you, Neil. Ken Bremner.
Just to make the point on vaccinations, the headline figures you see are just clearly an average. There is a considerable variation amongst professional groups when you actually unpack that. And we just about mirror the national position, with 51% of our frontline staff having had some vaccination. But that masks a variation that's, we've got nearly 100% uptake in doctors. Yet we have 41% uptake in allied health professionals and 44% uptake in nurses. So the messages are getting through to one part of our population, but not to them all. So if we are going to do some work, as Neil suggested, it's really focusing now on how to, now I don't know what the answer is to this, because we can't force people at the end of the day to have these vaccinations, but I certainly hope we can improve those figures in our frontline nurses and AHPs.
Okay, do you want to say anything in response to that, Neil?
No, it is true. We do see variation amongst professional groups. It's just understanding the reasons. And as I say, work has been done, which we can bring back and then decide to make some sensible next steps of some further engagement work we could do. Sam?
Well, I mean, we do have some proven methods. So, for example, the RSV vaccination in pregnant women, I think we're the highest performer anywhere in the country. And we have a targeted campaign that's been designed by people working in those services and expectant mums. So I think, Chair, we should commit to do a piece of work which is about going out, listening, seeking to understand, using our behavioural insights experts to bring back a view to the board. And I think we have to do that early on in the summer to inform the next campaign. And we should set ourselves a goal of a very significant improvement in the uptake of the vaccine. But I think we've got to keep this a live conversation. This has been mirrored everywhere nationally, and with the increased national communications, given the pressures on services, just in the month of January we did a further 3,000 vaccinations. So people were coming to it, but they got there really late. But we need to capture more people for the next year.
Just a comment from me on the Martha's Rule, and because I was on the committee that worked on that, the National Committee, but also your comment about the Patient Safety Centre. We are progressing. The arrival of the new chief nurse will speed things up. But interestingly, when we were thinking about the functions of the Patient Safety Centre, one of them would deal with resilience. So in other words, if you have said that you're going to implement a measure in to improve safety, then the subsequent data show that you've successfully done that. So with Martha's Rule, it is a resilience measure. Not all people and children who die of acute illness through deteriorating and no intervention occurring when it should is down to listening to the parents. But in testing resilience, you would certainly want to immediately look at and analyse those continuing incidents which are to do with situations where parents have expressed concern and Martha's Rule hasn't been implemented. So it's quite an opportunity to be very dynamic and not just put out incident reports and let them trickle down the system, but to try and interact and ask questions of the data in as real time as we can. Okay, so thank you very much. And we're on now to the Finance, Performance and Investment Committee.
Thank you. Just in terms of the actual report that you can see, that has the minutes of the meeting that was held on the 7th of November. So I'm not going to go through the points on there because if people want to ask any questions, then we can pick them up then. But then the next meeting did take place on the 3rd of December. I just want to thank Dr. Mike Smith as Vice Chair for stepping in at very short notice, actually, when I was taken ill. So I really appreciated Mike chairing that. But I'm just going to pull out some of the key points which are up on the slide from that particular meeting. So from a financial perspective, obviously we were given the financial position for month 7, including some of the risks, etc., and the progress that was being made. And also as well, we were given some updates on the financial and operational planning, when we were going to receive the planning guidance, etc. And then finally, from a financial perspective, there were some updates given and some underlying deficits as we go through the sort of the medium-term financial plan for the next 3 years. And again, we would have to say that was hugely challenging. But I know that David Chandler will give us a bit more current, up-to-date financial perspective when he does his report. From a performance perspective, there's a couple of things that were noted, that the improving performance in terms of adults with learning disabilities and autism inpatient, both Secure and ICB Commission, so there was some movement made on that, but there was still a little bit stubborn in terms of the specialised commissioning from the Secure perspective. That remains a little bit static at the moment. There was some deterioration noted in urgent emergency care performance, and specific reference obviously to 4-hour A&E waits and ambulance handovers. And it was noted in the meeting that there was remedial action in train at individual provider levels. From the point of view of, we did talk about deep dives. I know it's the sort of phrase of the last few months, but deep dives in terms of examining in a bit more detail at the Finance and Performance Committee what we would look at. And within that, the virtual wards came up as part of that supportive care, and also for our A&E waits. And we will be having a deep dive into the virtual wards. And I think one of the conversations that took place was around, if you make the topic so broad, you don't get into the details. So that was one of the things that the committee decided that they would narrow it down a little bit. And then finally, in terms of the role that we play regarding the infrastructure board and the oversight of that, there was an outline of planning and potential overspends management and how that was going ahead. And obviously we do that on behalf of the ICB, and then it reports up to the board in relation to that. So I don't want to say much more, but Mike, I don't know if there's anything you wanted to add from your perspective from the meeting.
No, thanks, John. I think that's a good summary. The only other thing to add regarding the deep dive topics was an idea that we would, as the FPIC committee, would do some of the deep dive work and ask the probing questions, and then surface to board anything that we felt was particularly relevant insights.
Thank you, John. Graham Evans.
Thank you, Chairman. Thank you for the update, John. Just in terms of the infrastructure strategy itself, in the board purpose, it mentions the feedback that we were expecting in November of last year. We actually received the national feedback in December, and as anticipated, it was a very positive response that we received from the national team. There were a number of minor amendments that were requested with a deadline of the end of February. So the intention would be that we've established a task and finish group to undertake those amendments, keep it in the current style of the existing strategy, and we will then bring it back through the necessary governance for further update and assurance. Thank you, Chairman.
Thank you very much indeed, Graham. Sam.
Thank you, Chair. Just to say, I really welcome the committee's deep dive on virtual wards. I think it's really evident when you look across that there is some variation, and it's just a question really, is this a sort of a collaborative piece of work with the Quality and Safety Committee, or is it a pure sort of finance and performance review?
Good question. I think probably doing it through Jacqueline and the team, it will link across the quality. So I mean, one thing that we've tried to do is not be repetitive and hearing so many things in different committees. So we'll receive it, and then where it goes after that, I think will probably be part of the discussion within the committee itself. So I wouldn't like to be ultra specific. I'd just like to see how it goes first. Is that a fair assessment, Jacqueline? Yeah.
So I can reassure you, Sam, that we're taking a rounded view, looking at utilisation, trying to draw some soft feedback from the implementers about how it's going, and also looking at the financial position as well.
Good. Thank you very much to the Audit Committee. David Stout.
Thank you very much, Chairman. The report on the agenda sets out the confirmed minutes of the 10th of October and also the highlights of the meeting on the 9th of January. There are routine standing items on the agenda: risk management, finance, internal audit, external audit, counter fraud are all standing items, and generally you're happy with all of those. There are three things that I'd like to mention specifically. We considered the ICS financial grip and control review, which David, I think, covers, and David Chandler covers in his report, and that was a very good report carried out by internal audit and also by PwC, and we wait with interest to see what action plans will now be developed by the individual organisations, including the ICB, to actually take on board the comments that were made by internal audit and PwC. But a good report. We've got a new external auditor and audit manager carrying out our external audit for the new year. I just pause, stop and take a breath. There's always a little bit of risk when you have a new audit manager and external auditor, but they're very experienced and it's the same firm, so hopefully it'll be fine. Crossing my fingers. Crossing my fingers. The deadline for submission of the annual accounts is moved, it's a bit tighter. It's been moved to 23rd of January, so that's 23rd of June. So January would be hard pushed to do that for January. 23rd of June, so it's a week earlier than last year. Routinely, the department keeps squeezing the service, making it tighter and tighter, but I'm sure we'll be fine. I'm optimistic we'll be fine. And the last item is freedom to speak up. The Audit Committee has a watching brief on freedom to speak up, a very, very important area. Our freedom to speak up guardian, Kate Holliday, is retiring 31st of March. And I know Sam and the People Directorate are looking at how we organise ourselves subsequently to be fit for purpose. I'm particularly excited by the concept of champions, because that will obviously complement the work of the Guardian, but we obviously need to maintain the work that Kate has started, because as we go through, we discover there are benefits. I mean, not only benefits to the individual, but benefits to the organisation, you know, on the back of people speaking up. I'll take any questions on anything on the agenda.
Are there any questions or comments for David? No, thank you very much. Item 12, the Integrated Delivery Report, and Jacqueline Myers, Chief Strategy Officer, is going to present.
Thank you, Chairman. I should just warn the board that I do have a bit of a cough. I'll do my best. It's a seasonal danger, isn't it? I did hear the presenter on Radio 4 coughing in the middle of her presentation this morning, which may be slightly better. So, as usual, the board has before it the full integrated delivery report. It's very detailed, and there is lots of information for both information and assurance there. And as ever, I'm happy to take any questions on the detail in the report. As we have done for the last couple of months, I'm going to choose to use my presentation time to bring the board slightly more up to date in terms of some more recent data. And so what we have on the slide before you, and it's also in the board pack, are the performance headlines from the data that was published just about 2 weeks ago, which for urgent emergency care is December data, and for most other metrics is November data. So I'm just going to make a few remarks around the key areas of performance that we like to keep an eye on, starting with urgent and emergency care and these December data. So further deterioration across most of the key metrics compared to November. Now, we do know that performance against these standards is highly seasonal. Nonetheless, we remain concerned that we're not delivering the rapidity of care that we would like to see across these standards. I'll just draw out a few key notes for you. It's pleasing to see that in terms of our Category 1 ambulance response times remain the best performing. Our ambulance trust that we take the lead on, North East Ambulance Service, remains the best performing ambulance trust in the country, and is achieving 7 minutes, which is the required standard. Against Category 2, which is the next most urgent ambulance response time, we did see deterioration compared to November. 37.49 was the average response time across the month. What I am pleased to report is that's considerably better than the previous December, which was 47 minutes, and the one before that, which was very regrettably 92. I did a bit of a quick look at the year-on-year comparison of what was going on in December, because December was very pressured nationally and also locally, as Sam commented on earlier, indeed Sir Pally referred to. So we did see more ambulance handover delays than we'd seen in the previous year, and slightly more 12-hour delays in department, which shows you the level of pressure. And when we tried to sort of dig into the reasons for this, the main cause seems to have been the high levels of flu. So compared to the same time last year, we had more than twice as many patients in inpatient general and acute beds with flu. And indeed, we were struggling with flu more significantly during December 24 last month than the rest of the country. So whilst across England at that time, 5% of general and acute beds were occupied by patients with a positive diagnosis of flu, it was 8% across our providers in North East and North Cumbria. And that kind of explains why, if you look at the last figure there, our no criteria to reside patients who were ready for discharge but waiting for supportive packages of care and therefore still in hospital wasn't as high as the previous year. And indeed, overall bed occupancy wasn't as high as the previous year, but finding the right beds for the right patients when we had high levels of flu patients waiting for admission to a bed where they could be isolated from other patients to protect them from an ongoing transmission of the infection was a real sticky problem for us. And as Sam also referred to earlier, I think perhaps the overall figures that you see for the whole system obviously don't allow you to see that within that there were some really significant peaks of activity. And I'd just like to echo my recognition and thanks to the way that the system responded to that. In particular, I think we saw a better than ever supportive response and fluidity of direction of our ambulances, so that when we did have particular sites that were experiencing concerns, we were able to provide some relief so that the patients who'd already been delivered to that site could be cared for safely. Just in response to your question earlier, Sapali, we don't have a national data set which collects specific data on temporary escalation spaces or corridor care, however we might describe it. I think that's probably likely to be a development in the near future, but as we'll be hearing later, we do have a process that we've put in place between the Nursing and Quality Director and my own system coordination centre to make sure that we have oversight of where those sorts of arrangements are being put in place because of extreme pressure in terms of the number of patients arriving relative to the capacity to deal with them. And one of the things that's been really helpful and pleasing to see over the last few weeks is that we've had a lot of senior nursing presence involved in those meetings to try and agree what the right thing to do is when we're facing pressures in the system. Turning to the cancer performance very briefly, if I may, Chairman, you'll see there's a couple of green arrows, but of note is that middle figure of 70.5. Folks may remember that the national standard this year for the 62-day target, which has been reintroduced for the first time as a requirement since COVID, is 70%. And so the ask is that everyone achieves that by the end of March. So it's pleasing to see there that in November, I think it says November, we did for the first time exceed that 70%, and we are seeing a statistically significant trend in terms of improving performance against that complete target for urgent suspected cancer referrals, getting their first definitive treatment or their benign diagnosis within 62 days. So good to see that. And we're also continuing to meet the faster diagnosis standard, which is that people get a diagnosis within 28 days of referral, 80% there, as you see. Turning to planned or elective care and looking at the picture there, we are continuing to see the very longest waiting numbers reduced, and of most significant note is for the number of people waiting over a year. Now it's still over 5,000, so there's still a very long way to go here. People will recall that before COVID it was very unusual for anyone to wait over a year. We were talking single figures, so a long way to go there. But it has come down from being over 8,000 around 18 months ago, so I'm pleased to see that. We are struggling to eliminate waits over 65 weeks, which is basically a year and a quarter, isn't it? It is coming down slightly month on month. Looking at the most recent data that I have access to, it's not validated, so it tends to be slightly overstated. We have seen that over December and the early part of January, we've seen quite slow progress. Indeed, nationally, there was a safety instruction to step down elective work if needed during the very peak of flu, which has had an impact on the number of long waiters that we've been able to treat. So we're still making progress on that, but it's slow progress. And the last thing I'd like to draw out, because I think it'll be relevant to my later presentation when I'm going to talk to the board about the recently published elective reform plan, is that our overall waiting list size, you can see that's just over 350,000 people. Well, it's 350 it's not people, it's operations being waited for or consultations being waited for. It's actually about 320 unique people, 320,000 unique individuals waiting for 350,000 pathways. But anyway, I digress. It's pretty static is what the point I want to draw out. We have seen improvement in the sense that until a year ago that was still the trend was very much that it was still growing and had continued to grow since we came out of the sort of 2020 COVID period. We have achieved, with all of the extra activity and other improvements that we've delivered, a kind of steady state. But certainly it's proving difficult to significantly reduce that waiting list size, and I think that'll be a topic of conversation later. Turning to the mental health measures, you'll see there that we're seeing a downward trend in terms of the two metrics that we're measuring this year around talking therapies for anxiety and depression. So we're not yet achieving the reliable recovery rate of 70%, or the reliable improvement rate of 70%, or the reliable recovery rate of 50%. This is something we're very alive to. We did hold a system-wide workshop, which was very well attended in December, just trying to regroup around these services and think about how we can both improve their efficacy and also improve their reach in terms of the volume of patients we're able to support with talking therapies, as we all know, are very well recognised and evidence-based therapy. So hope that we can bring to the board some progress on that piece of work in the coming months. In other metrics, there is some good news in terms of good progress being made around the diagnosis of dementia rate, and indeed the health checks that we deliver, physical health checks that we deliver for people who have learning disabilities, which is good to see. In terms of primary care, we've got some mixed picture, and I'm going to do a little bit of a sort of overview of primary care access. I think that was an ask from the last board, Chairman, so I'm just going to share a few slides. Before I get into these slides, also in the pack around, so just focusing on access to general practice appointments, kind of want to note the limitation of the data that I'm able to share here, partly related to actually the limitation of data that's available to us, which relates to the historic agreements we've got about what's shared with the wider system, with the NHS, and therefore available to us as the Integrated Care Board. And that'll become clear as I go through this. But I think probably what we don't get here is a real richness of the picture of what's being delivered by general practice. And of course, general practice is just part of the broader primary care. But nonetheless, there are some interesting things here. And a bit of the context of looking at primary care access is that, of course, within general practice, there is some collective action going on at the moment relating to concerns about the contract and whether it meets the needs of the sector. So just to draw some headlines out of these slides, people can have a look at them at leisure, but what we're seeing is that overall we are doing more primary care activity than we were doing in previous years, and probably of most note is that bottom statistic, which if you look at the detail, we're forecasting 21 million appointments for the year of 24-25, and that, if it comes to fruition, will be 5% more than we did in the previous year. So you know, you can see that there are ups and downs, and in fact October 24 was our record month for activity. Some of that's related to how many weekdays there are in the month, as you know, as well as various other factors. But overall, the trend is that we are seeing more patients in general practice by the data that we're collecting here. And as I'll explain in a moment, I think that probably understates the amount of activity that's going on in general practice. This is just a quick look at how we compare to the rest of England. We are the blue line, and England is the sort of maroon line underneath. So generally speaking, we are increasing our rate of activity per 100k of population. We tend to provide more primary care appointments per 100,000 of population than the England average, although we interestingly track the ups and downs very closely. In terms of by status, it's a bit of an odd metric, but this is about the number or percentage of patients that have an appointment made and then in the event do not attend that appointment or are not brought to that appointment for any reason. And we fare slightly better than England on here is the headline message. So 5% of appointments are not taken up across England, but it's only 4% in North East and North Cumbria, which is good to see, although obviously there's still a significant number of appointments not utilised in the context of that 21 million I just spoke of. This is a slide that just looks at how quickly we see people when they request an appointment, and you can see that we're slightly less timely than the rest of England. So 3.5% fewer of our appointments occur the same day or next day, and 3% more occur over 7 days. So people are waiting slightly longer to be seen in the North East and North Cumbria than the England average. This is a slide of appointments by type, and when I dug into this as the team pulled the data together, I just want to start by explaining what a virtual appointment is, the bottom right. That's essentially what we think of as a video appointment, or an appointment that you do on your computer where you are able to see the image of the practitioner as well as speak to them, as opposed to a telephone appointment, which obviously more obviously is one that occurs on the phone. But what's missing from these data is quite a significant chunk of activity, and we're probably all anecdotally are aware of this, which is where you're able to contact your practice and perhaps ask them a question. So many of our practices now have a service where you can fill in a form and make requests to the practice, and then often that request can be met through a response via email, and we don't currently have a way of capturing that activity at all. So that's the key point I wanted to make, that I think as well as this overall growth in activity, we're missing a really growing and significant chunk of activity, which is the sort of email appointments. And the GPs on the board may want to sort of comment on that and give us their anecdotal sense of the degree to which they're doing that sort of activity, rather than these 4 types of activity that are recorded in the data we're able to access as an ICB. But you can see here that the face-to-face, we do over 5% more proportionally of face-to-face appointments than the England average. We can debate whether face-to-face appointments are the gold standard. I suspect a mixed economy is probably appropriate depending on the needs of individual patients, but certainly you can set that face-to-face volume against the timeliness issue, because potentially it takes a little bit longer to see a patient face-to-face. So you may say, well, we have perhaps slightly less timely in terms of the same-day appointments, but we are delivering more face-to-face. There or thereabouts, as you can see on the home visits, and the face-to-face directly offset by slightly fewer telephone and virtual appointments. And this is just another way of seeing those data, but also how they're changing. This graph is not particularly helpful in terms of its 0 to 100% scale. So this graph's perhaps slightly more interesting. This shows you by our local delivery team, so dividing our population by our 6 local delivery teams. And what you can see here is that in recent year or so, we have seen quite a rapid adoption of virtual appointments, and a particular note in North Cumbria there, the top line, which perhaps reflects their rurality, and perhaps this signals an opportunity for more change going forward. So that was the I wouldn't want to describe it as a deep dive. It probably doesn't meet the criteria that we set in the Finance and Performance Committee, but just a bit of an overview of what's going on in terms of primary care access. As ever, happy to take any questions.
Thank you, Jacqueline. Questions, comments? Mike Smith.
Thanks, Jacqueline. I think that was the general practice summary was really clear. That just on virtual appointments, just to clarify the technicalities of that. So the reason for the variety of virtual appointment rates is more to do with the technicality and the way it's recorded. So it isn't just video consultations; they are actually very rare. It is often those online consultations you described that are being accounted for in this way, but actually practices have to log them as individual appointments in their appointment book. Most practices don't do that because that's just an additional administrative task that doesn't add any value. So often it's to do with the way that practices operationalise that. That explains some of that variety, and that may explain why we look a bit worse nationally, because we haven't pushed practices to do that as much because it doesn't add a lot of value for patients. But as you rightly point out, a lot of that work is going on.
Sarah Malik.
Thank you, Jacqueline. That was a really insightful and comprehensive report, and I enjoyed reading it. There were 3 things that stood out to me in the report that I just wanted to sense check with you, if that's all right. First was obviously the dip in primary care appointments per month, and I guess the question that was going around in my mind, having had the vaccines conversation, was that had the vaccines impacted? Was it workforce fatigue, or were there other factors at play at that, which would be useful considering that we're quite a considerate ICB and we like to know the soft intelligence, don't we, of what's affecting our system. I think following on from that soft intelligence, I was just looking at the number of services that are available for residential social care providers and community social care providers, and I noticed there's been a decrease in the number of services. I wasn't sure whether that was reporting or whether we actually had lost up to 20 providers in residential, and I think, there was about 14 providers lost in community social care. So I was just curious to understand if we had insight into what was happening there, because obviously they form a large part into how our hospitals function in terms of getting patients repatriated back into the community for care as well. And obviously I just wanted to pick up on the SIPs, the number of under 18s in our area seeking mental health support. And obviously we know that roughly 20% of our region are under 18. It appears that 1 in 10 are seeking mental health support, which is quite substantially high, isn't it? So I was just curious on your insights and thoughts around those.
Thanks, Sarah. I'm not sure I can do all of that justice here today. So, I mean, in terms of your middle question around the kind of changing provision, I think I'll have to set that way and have a look at that and try and provide a kind of more detailed response to that. On your latter question around the number of children and young people seeking mental health support, we've probably got others around the table also who can give a clearer insight to that, but it's definitely a national trend. We've seen really significant growth over a number of years, kind of over the last 10 years, but accelerating post-COVID in terms of the number of children and young people presenting to mental health services. And it's a mixed picture. I think we've spoken previously about within that, there is a really significant neurodevelopmental growth that we are trying to get our sort of sense around and think about what other models have approached to that particular demand may be. And obviously we're working with our providers to try and meet that demand in terms of looking at the services. In the report you can see they were doing quite a lot of work on community service volumes and understanding how we're doing in terms of waiting times and trying to take a much more rigorous approach to that. So I don't know if I can give you any insight as to why it is. You know, it's probably kind of very broad, complex, societal issues and better understanding and identification and so on. But it's certainly a massive challenge for us locally and nationally to try and meet those levels of demand, and that's pushing through to very long waiting times in places and so on. Yeah.
Thank you. I'm going to be a bit tight on the time. We've got 4 people wanting to come in. Levi will come back. But I need to just mention Lisa Taylor, our partner member from the voluntary community and social enterprise sector, has sent in a comment on this item suggesting that on the children and young people's data, the creation of a children and young people's health research network, which apparently has been supported. Bids have been sent to NHSE, it's been successful, involved the ICB, the research community and the VCSE sector. And in its early stages, but an opportunity to carry out some work to go deeper into children and young people's data. Tom Hall.
Thanks, Chair, and thanks, Jacqueline. Excellent report. As ever, there's so much information in here to go at. It's hard to pick where to start. One of the things that really drew my attention was the percentage of people with learning disability receiving a physical health check, and likewise in the report there's the percentage of people with serious mental illness receiving a health check. Both those figures are, although I think for learning disabilities it is an improving position, they are kind of significantly lower than we might hope for, given the clear disparities in health outcomes that people with learning disabilities and serious mental illness face versus the rest of the population. So I guess the question is kind of what's our level of grip on those particular health checks, and what can we be doing again as a collective to increase that?
Thanks, Tom. I mean, just to say on both those metrics, they can be slightly deceptive in that they are metrics that are cumulative across the year. So we start 1st of April at 0, and then we aim to meet our target by the end of March. And having been a watcher of these metrics, this is our 3rd cycle. There does seem to be a bit of a push within general practice to get these checks done to meet the standard in the last quarter. So in the last 2 years, we've seen a real step up across Q4. So these data are quite elderly. Actually, I think they're September. It takes us a while to pull these data through. So we do keep a close eye on it, but certainly based on previous experience, we have seen a much better performance than this would suggest by the time we get to the end of the year, which suggests that people across the course of the year are getting their checks. But happy to do a bit of a dive into that and see if I can bring a better forecast for it to the next meeting.
Thank you. Dave Gallagher.
Yeah, thanks, Jen. Thanks, Jacqueline. Really helpful report as ever. Really struck by the focus on general practice in primary care and the health warning on the data. There are similar, probably worse challenges with the data for the rest of primary care, but it'd be really good to work on that and just try and look at that in a bit more detail going forward. So maybe it's something that we'll weave into future reports.
Ken Bremner.
Just a very quick one, Jacqueline. The only thing that would be quite useful to see with the GP data is to map against that any changes in the workforce, and tease out what's a growth because our manpower has grown or because our productivity has grown, or indeed the opposite.
Yeah, thanks, Ken. So I can certainly include that in a future report. Thanks.
Anne Fox.
Thank you, Chair. Just to come back onto the health checks, because I chair the Learning Disability and Autism Network, and as Jacqueline alluded to, it does tend to be how that work is profiled over the year just because of other activity that is taken on through the year. And we do each year, I think, have performed very well, but are always sharing the learning about how we continue those improvements, not just to actually demonstrate that the health checks have been done, but that the quality of the health checks that have been done have actually had the required impact that we would like to see. So always something that's up for discussion in the network meeting. Thank you.
Levi, did you still want to come in?
I think John and I are probably going to make very similar points, really. So we can save this for one of the committee meetings. I suppose on the CYP access, it is worrying, but if anything, I think the numbers will be higher. What that metric won't capture is the less formal support, a lot which is provided through education settings, voluntary sector agencies. So it absolutely remains an area of focus for John and I and partners.
Yeah, absolutely. I may come in to add to that. I think it probably is a more complex, deep dive discussion, but the numbers are exceptionally high across different bits of the system. So those mental health disorders that are requiring clinical responses, but also that broad range of demand for neurodiversity and the pathway through. So it's quite a complex mix, but the numbers are exceptionally high, growing and quite scary in terms of their scale.
Yeah, thank you very much. And it's a lot of data. So if you can't sleep, you've got a chance to review it further and come back with questions and comments, which we'd welcome. On now to the finance report, which is David Chandler, Chief Finance Officer.
Thank you, Chair. So on the paper on the agenda today, you've got the month 8 finance report, and as with Jacqueline, I use this opportunity to bring the latest.
David, I'm so sorry to. There is a list of conflicts of interest that we need to read into the meeting.
Yes, apologies for that. I just thought I'd better read them out. So please bear with me because there are quite a number of you conflicted for this item, so I need to read them out. But to confirm, the details of the conflicts are on our register of interest, which is publicly available on the website. And to confirm, you can take part in the discussion, but not the decision for each of the organisations that you are conflicted for. So as I say, please bear with me because they are a number. So for County Durham and Darlington NHS Foundation Trust, it's Neil O'Brien and Ken Bremner. Gateshead Health NHS Foundation Trust is Ken Bremner, David Chandler and Syra Malik. Newcastle upon Tyne Hospitals NHS Foundation Trust, Ken Bremner and Levi Buckley. Northumbria Healthcare NHS Foundation Trust is Ken Bremner and Sam Allen. South Tyneside and Sunderland NHS Foundation Trust is Ken Bremner, David Chandler and Syra Malik. North Tees and Hartlepool NHS Foundation Trust is Ken Bremner, Graham Evans. South Tees Hospitals NHS Foundation Trust is Ken Bremner and Graham Evans. North Cumbria Integrated Care NHS Foundation Trust is Ken Bremner. Tees Esk and Weir Valley NHS Foundation Trust is Ken Bremner, Rajesh Nadkarni and Tom Hall. Cumbria Northumberland Tyne and Weir NHS Foundation Trust is Ken Bremner, Rajesh Nadkarni and David Chandler. And finally, North East Ambulance NHS Foundation Trust is Ken Bremner and Graham Evans. So thank you, Chair.
And can you just say something about the constraints of the participation?
Yeah, it's just that you can take part in the discussion, but it will be noted that you will not be counted for the decision, and we'll minute that accordingly for the next meeting.
Thank you. Sorry to have interrupted you, David. Go ahead.
That's absolutely fine, Chair. So as I was saying, I'll trying to bring the latest information into the verbal update as well. So I'll take the paper as read. I'll just pick up the main points for you today. So in terms of our main financial duties, I'll touch on 3 of the 4 today. The first one is for the ICS to achieve the break-even duty. You'll be aware we've now received that £50 million from NHS England, so we have a break-even plan. The important point to note about that money is, if you like, lent to us on condition that we achieve break-even. If we don't achieve break-even, there's effectively a penalty that we'd have to repay that money back over 3 years. And that's important. Obviously, we want to avoid that as much as possible. We are on track, as you can see in the report, to achieve break-even as an ICS, which is the ICB and the Foundation Trust combined. There are pressures. We see pressures on pay award funding, which we are still working with NHS England to identify exactly what pressures are where and what's the cause of those and what we can do about that. There are pressures around high-cost drugs, especially NICE-approved drugs and devices. We have written to NHS England about the nature of those from a system point of view, and we're having conversations with them. I think it's fair to say the affordability of NICE drugs is not just a local issue, it's a national issue. And there are other issues such as the backdated pay grade claims that some organisations have had to pay as well. So there's a combination of factors that put risk into the system. At this moment in time, the main challenge we had in one foundation trust to deliver its plan has been identified, and we've agreed a mitigation plan for that. So as I say at this moment in time, we believe we are on track to deliver our financial plan and crucially avoid that £50 million penalty. In terms of the ICB itself, again, we're on track to achieve our planned surplus. We do see pressures in prescribing and CHC, which we're offsetting in year. On CHC, our Director of Nursing is taking forward a transformation plan, which we believe will also mitigate some of the financial risks that we're seeing currently in that area. That probably have more of an impact in 25-26 than in 24-25, to be fair. And we've also had some slippage and some recent rebates, which we are utilising to offset financial risk in the system as well. They weren't planned for at the start of the year, but obviously they're very welcome. Just talking about financial risk, just to remind everybody, at the start of the year, we had unmitigated risk of approximately £160 million, which is a very large figure. We've been mitigating that through the year. As we go into the last quarter, we believe that risk is somewhere in the region around £40 million. So you can see it's been steadily reducing. And we do believe we'll have mitigations that we've got now, or we will have between now and the end of the year, that will allow us to offset that risk and deliver break even. I think it's fair to say the bigger risk share is more in respect to 25-26 now than it is around 24-25 delivery of plan. And I'll come on to that in a second. The capital, you may have noticed there's like a red highlight on the capital part of the report. That's mainly due to an accounting standard issue, and we're confident working with our regional colleagues that that won't be an issue in terms of delivery come year end. So that's not one I'm particularly concerned about at this moment in time. In capital, we expect to fully deliver. In terms of next year, we now have the planning guidance. We expect to get the planning guidance on Thursday. We have had snippets of that planning guidance. We do know that it's going to be a very challenging settlement for us as an ICS. We've already started our planning in terms of how do we mitigate and manage and produce a plan that is acceptable to NHS England in line with their expectations. We don't believe that will be possible without making some difficult decisions in terms of how to make best use of the limited resources that we receive as a system, and obviously more of that will come to board in the near future and through FPIC. The timetable is basically draft plan end of February, final plan end of March, and I'll be working obviously closely with colleagues like Jacqueline to produce an integrated plan that will come to board in due course. As David Stout alluded to, we have had the output report from the Grip and Control Process Review. That's been done with Audit One internally and some external support from PwC. That report has identified generally good processes in place to manage our financial challenges in year. It does identify there are areas where controls can be improved, such as on pay and non-pay in individual organisations. Areas where PMO, that's project management, can be improved in a number of organisations. And also, it does identify that we have traditionally over-relied on non-recurrent cost improvement plans, and it's vital going forward that we have more recurrent transformation plans if we're going to be more financially sustainable going forward. Each organisation and as a system has effectively now produced an action plan or in the process of doing so, and we'll be taking those through both the Audit Committee and the Finance Committee just for assurance purposes. They will also go through individual organisations, relevant committees as well for assurance. The final point I would just like to make in terms of the paper, and this is probably where a lot of the issues come around conflicts of interest that were just mentioned before. So in the paper, you'll see that I've asked for permission for us to recognise pressures in the foundation trust sector of the ICS, and in line with that, reduction of the ICB surplus by £50 million to recognise those pressures. Those pressures are in organisations that generally are in deficit, and the purpose of that would to recognise those pressures within contracts and allocate that funding so we can offset the cash pressure that those pressures put on organisations. I just want to be really clear, this is not about allocating cash to an organisation that then can then spend it. It's more to reduce those borrowing costs or need to borrow money from NHS England. Just to share with you that the cost of borrowing is around 6%. So it makes more sense for us to recognise those pressures under contract rather than an organisation needing to borrow money. But I just want to be really clear that is in respect of, if you like, moving cash around the system. It's not about allocating funding an organisation can spend. And if we were to recognise those pressures with NHS England approval, that money would, the condition would be that the overall position of the ICS is neutralised so that we still achieve break even. So the position on FT might change and the position of the ICB would change, but the net position would be break even. Okay. I know that can be quite a technical area to talk about, and we'll have to take any questions on that one, but hopefully the report and my overview has explained the nature of that proposal in the paper. That's all for me, Chair, and we'll have to take any questions.
Thank you, David. On this item, we have a question, or a two-part question submitted by a member of the public. So I think it would be helpful if we heard from Claire and got your response, David, and then it can be built into any questions or comments that the members want to make.
Thank you, Chair. We've received two questions from Keep Our NHS Public North East. The first one is, which patient-facing services in which geographical areas are expected to deliver the largest efficiencies, and what is the predicted reduction in patient services that will result? The second question is, will the proposed deep dives be conducted in-house or by external consultants? If external consultants are undertaking this work, which firms have been contracted and what is the agreed cost for this work?
Okay, so I'll do my best to answer those questions, Chair. So in terms of efficiency requirements across places and across organisations, 24-25 has been a challenging year. And every organisation will have had, and every place will have had a target to achieve. That will vary by place. Within the ICB, the target is generally a set rate of around 3 to 4%. Within a foundation trust, it can vary. In terms of the deep dive question, in terms of what deep dives have we or have we not been doing, the only deep dive exercise that we've really done at an ICS level is one that we did, as I referenced earlier, which was the review of grip and control measures. And we did that following the NHS England specification that was announced. It also had a price guideline, and we followed that to the T. We actually did quite a lot of that work internally using Audit One, but there were areas that Audit One could not deliver. And in that situation, we employed an organisation called PwC to do those relevant elements. The internal audit work was effectively free because that's part of our internal audit plans. The PwC cost was £200,000, which was well below the limits and expectations from NHS England in terms of that work. I hope that answers the question that's been set, but if not, I'm more than happy to put something in writing as well.
Thank you. Questions and comments on David's report? Yes, please, David Stout.
Yeah, thank you very much, David. That's really helpful. David, out of all of your report, the one that I spent more time looking at, and I'm still looking at now, is one on workforce, the very last slide there. And this shows, for the benefit of people who aren't looking at it, that there's been a 2.1% variance to plan on whole-time equivalents on workforce, whereas on actual expenditure, the variance is only 0.3. So I'm trying to reconcile, there's a number of reasons why that could be. One is how robust are the individual numbers here. But given that, and given the grip and control reports that you've just referred to, and one of the comments that PwC made was that perhaps this part of the world has not been as good as some other parts of the country on doing transformational change and recurrent savings. and that involves workforce. I wonder whether, and we talked lots about deep dive, I wonder whether we should have some sort of deep dive, there probably is a deep dive going on now for all I know, and have it reported through the committee structure around the topic of workforce, just so that we understand how robust are the numbers, how the numbers relate to the actual spend as best we can, what people are doing on their action plans under PwC, just so we can understand that looking through the eyes with workforce in mind.
Yeah, so to come back to you, Dave, that's okay. So the first one would be, I think that there is a need to get better in terms of aligning the financial plans with the workforce plans. We made strides last year, but I still would say they're not perfectly aligned. Yeah. So sometimes it's better to look at how does actual numbers compare year on year rather than against plan. And it's also, we need to be aware that sometimes there are things that happen in year where a service might move from maybe, I don't know, being a PFI provider and it might come in-house, etc. So you get all those bits and pieces that go on, and obviously the numbers of workforce don't always relate exactly to pay for a variety of reasons in terms of pay increases and what have you. But because you should probably be aware that what we actually thought was going to be the pay rise this year was actually a much higher level. So you get all those changes against plan. The second part of your question in terms of workforce and the output of the report from PwC, in terms of pulling that together and systematically and making sure it's reporting through to the right place and up to board, as you mentioned, for EPIC and the like, we do have a number of work programmes that we're working at system level, which picks up on some of the challenges, if you like, that are raised by PwC. So we have work programmes currently working in areas such as procurement, workforce, elective, and system reform. They are generally led by an ICB, a chief executive, could be by the ICB chief executive, or more likely by foundation chief executive, or a medical director in the case of system reform. So they are work streams that are currently working and feeding up to our system recovery board, which then can feed up to FPIC, feed up to chief exec form, and ultimately up to here. In terms of how we share more information on that, etc., from an oversight and assurance point of view, I'm more than happy to pick that up with you offline, perhaps with Sam, in terms of how we can maybe just streamline some of that from assurance purposes. But to assure you, there is work going on in the work stream programme. They've been working on that instead by a chief exec from Gateshead.
Thank you very much, David.
Sam?
Yeah, I think just to add to that, I actually think it would be helpful, David, to do a review on this. And as David has said, there's a huge amount of work underway across all of the trusts in our system. Obviously, our main bit of expenditure is on the workforce, and equally, if we think about the workforce in terms of its links to quality and safety, and just reflecting on the questions that were asked earlier, I think it would be helpful for us to do a sort of a deeper review on this. I think it is incredibly positive from a finance perspective, the reduction in the use of agency, and that's been achieved through the provider collaborative working really closely together, but we are still seeing the whole time equivalent establishment increased, and we do need to tackle that. But equally, there are all vacancies across the system as well. So we do have a work stream as part of the System Recovery Board. It's led by one of our trust chief executives as part of our system recovery, financial recovery plan as part of this. But I think it probably would be helpful at some point in the future to bring a more detailed update on this back to the board. And I know Kelly would probably want to be part of that as well.
Thank you. Just before we move on, the request on this is to note the latest year-to-date and forecast financial position for 2024-25. To note there are still a number of financial risks across the system still to be managed, which David set out. And then finally, to agree the proposed approach to redistribute a proportion of the forecast ICB surplus across the ICS. So is everybody happy to agree that? Good, thank you. Item 14 on emergency preparedness, resilience and response. There's a self-assessment to be reported by Jacqueline. We just have 10 minutes for this item, so we'll need to be concise in presenting and discussing.
Thank you, Chair. So this is the third time the board has seen this paper, which is an annual oversight of the emergency preparedness, resilience and response assurance process and outcome. So the paper has two facets. Most importantly, it covers that process for the Integrated Care Board itself, which the board will recall is a Category 1 responder under the Civil Contingencies Act. So I'll focus on that bit of the paper most of all, because the paper is asking the board to consider the process that we've gone through and the outcome, and agree that we submit that outcome to NHS England as our formal submission for the 24-25 process. In addition, and I'll perhaps not focus on this so much, the paper shares some information about the role that we took in leading the assessment of our other Category 1 responders in North East North Cumbria, the 11 provider foundation trusts. So just thinking about the assurance process that NHS England that sets out and that the ICB has gone through, the paper describes in detail the process, which I think was very robust. It started with a self-assessment, but then a sort of check, challenge and moderation process involving both NHS England and the other 3 integrated care boards within the North East and Yorkshire region. Just to step back a little bit and do a comparison to the previous year, board will recall that last year we had a very root and branch review of our compliance with these standards, which was driven quite rightly following a kind of recognition of some of the learning from things like the Manchester Arena inquiry and indeed the Grenfell inquiry, and that we brought to board last year a non-compliant position, as did pretty much every integrated care board up and down the country, of 49%. So I'm pleased to report that we've seen significant improvement, and this year's assessment, which has been moderated as described, is partial compliance at 77%, and I think that's a fair reflection of where we've got to. Just wanted to draw out quickly 2 areas where we've got to do significantly more work to get to what we'd like to get to, which is substantial compliance, or perhaps eventually full compliance, which is 100% compliance. So the 2 areas are around training and exercising, and also around business continuity. In terms of training and exercising, essentially we didn't make as much progress as we aimed to do here, because we collaborated across the region on creating a new portfolio of training and exercising that would be used by all 4 integrated care boards. It really is a revolution I want to describe in terms of the depth and rigour of training that we put our on-call managers through, and it was only finally agreed and launched in October. I'm pleased to say that we are making good progress on what will be a 3-year cycle of working through that training and exercising, but at the point where we did this assessment in November, we felt that it wasn't reasonable to consider that to be substantially complied with. The second area where we made less progress than we aimed to do in our action plan this year was around our business continuity arrangement for our own services in the Integrated Care Board. There is, since the assessment's done, some substantial further progress done on this with a set of workshops with all of our directorates, and I feel pretty confident we'll get where we need to in the coming year. Again, it's not that we don't have business continuity arrangements in place, but making sure that they're rigorous and testing them to be absolutely confident that they're effective is still a work in progress. So as I say, I think that the sort of partial compliance at 77% is good progress. It's a fair reflection where we are, and I commend it to the board for sign-off. Just a couple of comments, if I may, briefly on the position in relation to our foundation trust. Without going into all the detail, you'll see that there's a similar picture there where we've seen pretty much all of our organisations make some progress, and I'm really pleased at the community that we've developed of practice across our emergency planning leads within the North East and North Cumbria. We've got pretty much full attendance of all of our providers at that monthly forum. We've built quite mature peer relationships between the pairs, so we've got 6 pairs now with our ambulance service pairing with North West Ambulance Service, so sort of 12th partner. And we had some really good check and challenge and learning going on across the year, and I think that's a really strong foundation for us together as a system to become only more resilient in the years to come. So that's all I'll say, given that we're tight for time, Chair, but as ever, happy to take
Thank you very much, Jacqueline. So, Pally Hungin.
Just very briefly, I don't need a detailed answer, but I am concerned about our preparation for IT hacking and ransomware. Can you assure us that we're as well up to speed to cope with that, should that happen?
I might defer to Prof Evans on this one, but to say that we have had a deep dive into those areas of preparedness. I suspect it's difficult to assure that we're completely sort of safe from any future attacks. And I think the way that the community thinks about it is it's not if but when we face those sorts of attacks. And there's no doubt at all that the level of resilience is not 100%, and that's to do with the kind of patchwork of existing systems we have of various ages and maturity. So I think we do have substantial risks in that area, Sapali, but it's an area that we do give attention to in terms of trying to make to mitigate the risks, but also crucially we've got really detailed business continuity plans so that when we do lose access to a system, as far as possible we're able to maintain safe services, albeit sometimes slightly slower services in terms of waiting times, while we work with suppliers to restore access to any interrupted services.
Ken Bremner.
Two quick comments. Firstly, can I just offer my thanks to Jacqueline and the ICB team for a much better process this year leading to the paper you've got in front of you. So thank you. I think all Foundation Trusts would support that, Jacqueline. And you're right, there's a bit of a community building, as you said. Pally, the second issue, there are some assurance mechanisms already available around cyber. I'm sure Graham would say it if I'm not going to, but Cyber Essentials Plus, for example, organisations are meant to demonstrate that. It doesn't give you complete assurance, but we're taking reasonable steps to assure ourselves we've got protection from cyber as best we can. But Graham may want to add a little bit on top of that.
Graham Evans.
Thank you, Chairman. And Sapali, just to give you confidence and to support what Ken has said, the former Data Protection Security Toolkit is now very much focused on cyber and data security. There are additional controls that organisations apply, such as the Cyber Essentials. So we've got an armoury of defences. We do, on occasion, sadly, have IT outage, which are not cyber related. So we are well versed and trained in how the whole business continuity arrangements. The challenge with cyber is what happens after the event and the clean-up and restoration of services, which is more of a challenge. We are developing, with our national colleagues, an approach to cyber strategy and an implementation plan. But fundamentally, business continuity will keep us going whilst we resolve the challenges that are technically applied. Thank you.
Thank you. I'm assured that something's been done.
Okay, then. I think we've finished this item. But just then to ask if you're happy to endorse the submission to NHS England as part of the annual assurance process of this area of care. Good. Thank you. So we're now going to have a short break for lunch and ask everybody to be back by 1:55. Thank you. We are now back online. It's the meeting of the Integrated Care Board for the North East and North Cumbria. And I'm very pleased to welcome the Chair and the Chief Executive of Tees, Esk and Wear Valley's NHS Foundation Trust, David Jennings, the Chair, and Brent Kilmurray, the Chief Executive. And we're very pleased to see you, and thank you very much for coming to describe the work you've been doing on your improvement journey. I'll hand over to Sam, who's got some brief introductory comments to make.
Thank you very much, Chair, and welcome to our colleagues from Tees, Esk and Wear Valley Trust, one of our two specialist mental health providers that deliver mental health, learning disability and autism services across the North East and North Cumbria, and indeed for this particular organisation into our neighbouring ICB in North Yorkshire as well. Just a few things I just want to share with the board. Since we became an ICB, we've obviously had a key focus on areas of quality across the system and in our NHS services. And indeed, one of the aspects of that we've looked at as a board has been receiving and responding to independent reports into various organisations, this organisation being one of them, and particularly around some of the failings at West Lane Hospital, and also the very sad and tragic loss of Christy, Nadia and Emily, names which I know and certainly in terms of these young people and the tragic loss of their lives have been deeply felt, first and foremost by their friends and families, and also in terms of the health and care community. I think when we see tragic losses like this, it's always incumbent upon us as health services to really examine and understand the causes, the lessons, and address those. And certainly over the last 2.5 years since we've been an integrated care board working with and supporting the trust, it's been evident at every stage the way in which the trust has taken responsible steps in order to address the findings of various reviews and indeed various regulatory reports as well from the Care Quality Commission. So I want to really acknowledge that with the organisation and also your colleagues. We know also that losses like this, it's difficult to, indeed, even with the passage of time, to fully get over. But in terms of the absolute commitment to address the learning and also think about that in the wider context of the organisation and the services the Trust delivers, there's been a real commitment to do that. And it's with that in mind that in the same way we've taken steps with the North East Ambulance Service and also more recently Newcastle Hospitals Foundation Trust, when they've presented here, that we receive your presentation today to get an update on all of the work that you've been doing, what's been going well, but equally where there's more to do as well. And I think we probably all agree that this work never stops, it continues, but it's a good moment in time for us to hear from you, to perhaps ask any questions that we've got on the improvements that you have been making, you are making, what more there is to do, and I think also what role we can play to support you in the system. Thank you.
Thank you, Sam. Over to you, David.
So Liam, Sam, colleagues, good afternoon. Thank you very much for the invitation. We really welcome the opportunity to take some time in your board to set out very much along the agenda that Sam has set out. Brent and I will do this together. we plan on 12 slides. I think you have a more detailed slide pack that we've already sent you with much more detail, and we've sort of taken highlights of that in terms of our presentation this afternoon. Would plan to take about 15 minutes and then perhaps 15 minutes for discussion, question and answer, anything that you want to put to us. I'm very grateful, Sam, for your introductory comments, and I think that captures entirely the intent of the Trust. We are very clear that we lead this Trust and that we have a duty to lead this Trust primarily on behalf of patients, carers and families, but that duty means that we need to demonstrate to the 8,000 colleagues that we work with and to yourselves and wider stakeholders that we have grip and control of the organisation, both in terms of historic issues that have happened and our response to those, but also then in terms of current and future progress of this Trust as it plays its part in the North East North Cumbria ICB. I'm just going to talk briefly to this first slide that we've got up with you in terms of that key message around grip and control, and I think that is a theme that will go through the slides that Brent will talk about in a minute. In terms of establishing a firm foundation and then building on that in terms of our strategic plan, our journey to change, which again Brent will touch on in a minute, because that our journey to change is our expression of the transformation that we want to make of this Trust and the outcomes that it delivers on behalf of members of the public, patients, carers and families. It would, I think, have been quite easy after the CQC reviews of West Lane to go through a process of ticking off a must and should checklist and say, hang on, job done. It predates my involvement in the Trust, but I think is absolutely credit to Brent and the leadership of the board back in 2020 that decision wasn't the one that was made, and that our journey to change is a much more fundamental transformation and cultural change piece for the whole organisation. That takes longer to achieve, but we hope to set out to you this afternoon where we're up on that. And I suppose the other thing I'd say by way of introduction is clearly we are cognizant of the challenges that face the whole mental health sector in terms of demand, in terms of acuity, in terms of the service model that we have for people with autism, our approach to learning disabilities. We're cognizant of a new government and its demands and challenges for the whole NHS, for the mental health sector and for trusts such as ours, and conscious of the resource constraints that we're operating under as well. This just sets out a bit of a timeline around that, our journey to change, which, as I say, is our strategic transformation plan. Brent will talk to some of the highlights, but the one that I want to touch on, and I've sort of referenced this already, is on the 2019 bar, the new chief exec appointed. And I think that was significant. Brent is too modest to say this, so I will say it on the board's behalf. He has been instrumental in the leadership that he has provided, excuse me, to the Trust. And his resilience over what has been a very difficult 4 or 5 years has been very significant in providing reassurance to the 8,000 colleagues we work with, reassurance to partners, and that sense of, yes, times are difficult, but we will move forward and we will be successful. Brent, do you want to pick up from that?
Thanks, Dave, and thanks for the comments. We thought it was helpful to set out our journey really on this timeline, because I think it does provide an opportunity to set a little bit of the flavour, really, of the sorts of things that happened. Sam obviously introduced this by mentioning the tragic incidents that took place in 2019 and 20, and clearly they were the antecedents then to a whole set of issues that played out subsequently, and the timeline really sort of characterises some of those kind of key issues. Obviously, there's a lot of other things that could have made the list. It's quite overwhelming when you start to put these things together to remember some of the steps in the journey. But I mean, obviously, what you can glean from the timeline is that at various points we were under significant regulatory pressure, intervention from the CQC at different times, where really the issue at play was about getting underneath some of those key factors very quickly, understanding the kind of, I guess, the core, the root causes of those aspects, and starting to put the improvements in place. At the same time, we chose, as Dave has said, to start to think about how we can set a vision really for what better looks like, how we can set a greater sense of clarity for colleagues, for patients and carers and our stakeholders, to know what we're about, what our role was and where we were headed, as part of that, I guess, that North Star approach. So we co-created our Journey to Change, as Dave has said, which has served as well in terms of navigating some of those kind of more pressing kind of short-term issues, as well as we've set plans for the future, which we'll touch on here. So that was a key thing there. But fundamentally, we've faced regulatory challenges, prosecution, obviously COVID, like everybody else, and the aftermath of that. We've seen some significant changes in our team as we've worked through. We've reorganised the organisation from top to bottom. We've provided a more simple, a more straightforward, a more streamlined governance approach, which went from 7 or 8 levels in certain places to just 4, so we can get that greater clarity of line of sight, and a really clear set of priorities around quality, safety and outcomes, clinical outcomes, that we've put in place. I guess this is just a snapshot, part of, I guess, some of our one source of independent assessment really in terms of our progress, and this represents 2 different points in time, December 21 and October 2023. And you can see that through the work that we've been doing, we've been able to demonstrate some improvements. If you just, even at this distance, you can see the difference in the colours on the grid there, which tells a story to me really around a better sort of overall performance, more consistency across what we're doing, and a stronger showing in some of the key areas. Clearly our safety rating still requires improvement. Much of that was driven by staffing concerns, as well as a backlog of incidents, which I'll talk about later, that played through. Just to add to this, our crisis service were inspected. Our crisis, our 136 places of safety, and our acute hospital liaison teams were inspected in May last year, and we're awaiting the final report, but we don't expect the rating to have changed, which I think is a positive issue for us as part of that. This is the aforementioned Our Journey to Change, so just encapsulated in a visual there. This has been our guiding framework. I think, again, part of the work that we did was to really try and achieve a simplicity in setting out what we were about and where we were going. 3 really clear goals about patient and carer experience, colleague experience, and being a great partner. I think the key bit that I think has been part of our guiding sort of force really is around those values, and having really consistent and constant conversations about the values and how they inform the decisions we've made. And we've had to make some really very difficult decisions as we've come through this journey. Again, it's in your pack, so apologies if you can't see it on the screen. When you track our last 3 delivery plans, I think you can see that we're getting a greater sense of clarity in terms of the key priorities. We're being less reactive to some of the key issues that we had faced from 2019-20, and we're being really much clearer in terms of our capacity and capabilities to actually get underneath and deliver and make progress with some of these areas. There's a clear shift from getting a grip of quality and safety issues to a more transformational focus in what we're doing. And I think that's evident from some of the conversations we're having around what's going to come in the next year as well. I just wanted to take a moment on this, looking forward or looking at where we're at in some of our transformation work. This is one example of the transformation programme that we've got underway, which is our community mental health transformation. I think it's been a really positive step for us. The actual model is moving us from something which is quite a traditional setup with community mental health teams across our geography, serving a range of different functions and purposes, actually holding quite a lot of cases on a kind of maintenance and long-term basis. And where we're headed with this is a system which is more focused on working with partners in the voluntary and community sector, within the social care sector, as well as other associated areas like education and faith groups and so on, through to a process of working with primary care and with third sector social enterprise partners in terms of some of that earlier help and earlier intervention and support, and a greater sense of clarity around our role as a specialist mental health provider around treatment and intervention services on a more episodic basis, working with people in a very focused way as part of their recovery and moving things through. I think it serves as a model for other things, other conversations that are likely to come in the 10-year plan outcomes. Clearly the mission shift around hospital to community is driving us very much in this way. And I'll show you in a moment, I guess, some of the impacts that we're starting to see from that. What we've been able to do is to create some physical hubs working alongside colleagues from the voluntary and community sector, physical hubs in Hartlepool, Stockton, Darlington, Middlesbrough, virtual hubs that are going to lead to more sort of place-based sort of physical locations in Redcar, in Cleveland, Chesley Street, Durham City and Easington. So some real progress there. So what does that mean? Starting to have some impact. These are the numbers from 23-24. This is for Durham and Tees Valley, where this reflects the impact that we've been having from the frontline mental health workers that we've put into primary care as part of that earlier help model that we've put in place, where you can see actually there's a significant impact in terms of the onward referral of people to specialist mental health services. Before these roles were put in place, all of that activity would have been referred to a mental health team, which then would have been added to a waiting list. They would have been screened and assessed, and potentially probably 50% or more of them would have been sent back as inappropriate referrals or not for the team, which clearly is an unsatisfactory experience for people and clearly sets people back. And what we've got here is something which is based on a principle of no wrong doors, working with colleagues to think about how we can accommodate people's needs more holistically, whether that be social issues, economic issues, family, isolation, those sorts of things, alongside their mental health needs. And as you can see, that we've seen a reduction in referrals, and actually we've been able to reduce our overall waiting list by about 50% as we're working through. So a real impact on people's experience of accessing services in a more timely and appropriate way, getting underneath some of their kind of core issues and the reasons for their presentations to services, and you know, a much clearer focus for us in that pathway. In terms of the progress that we've made, and obviously I've mentioned some of the challenges that we've faced. Clearly we have continued to be subject to quite a lot of independent assessment and regulation and assurance work, which I think has been welcomed largely, I would say. I've mentioned the 23 CQC report. You know, we obviously as a mental health trust have the CQC through our wards probably a couple of times a month as part of Mental Health Act inspections. So we have a regular drumbeat of feedback from the CQC on that basis. We've got Audit One, who are our internal auditors, and they obviously provide us with our regular flow of internal audit reports, but we commission them to do some separate and specific things for us as part of our journey around complaints, the duty of candour and restrictive interventions, and they were issues that came from our CQC report in 23, which we've been able to demonstrate significant progress with, and a clean bill of health in a number of those areas. The key one there is obviously the one that was published in the last week or so, the Niche report. They published last week an assurance review, which followed the independent reviews that they did into the 3 cases that Sam mentioned of the young women who died in our care. We had independent reviews published in late 22, and then a separate all-encompassing sort of governance review that was published in March 23. And as part of that process, NHS England commissioned Niche to come back and undertake an assurance review which looked at issues around practice as well as issues around governance. And it's pleasing to note that the report as presented by Niche to NHS England is a positive one and demonstrates that we've achieved implementation of all the key recommendations, and they're satisfied that we've dealt with all of the kind of issues that were raised as part of that. We've sat under mandated quality governance arrangements, quality board arrangements with NHS England. They've overseen a lot of this work alongside obviously input from the ICB. and working things through from that point of view. And we're hoping that as a result of the work that we've been doing, various of these assurance work, bits of work, that we can present a case to move from segment 3 to segment 2 and move back into the usual flow of governance under the ICB's leadership. Special word for Healthwatch there, Christopher. I did say that I would mention the work that you've been doing with us, very regularly, working with us across the Tees Valley in Durham, dipping into services and across service lines. A fantastic piece of work around the community transformation work that we've been doing to get the perspectives of people who use our services, and we welcome that work. We've had some of these pieces of work have been internally commissioned, so we've got the GGI there. I also add Deloitte to it, where we've had regular governance reviews undertaken to make sure that we are making the progress that we said that we would make on there. Perhaps if it comes up in questions, I can also talk about the staff survey if people are interested in that. Just moving on, aware of time, I think what this demonstrates is that this is about some work that we're doing at the moment to currently review our journey to change. It will be 4 years old in the spring, so it's timely that, obviously, having created a framework like that in the context that we did, that we take a pause now to reflect on where it's led us to, on what it's going to do for us, I guess, going forward. And we've been involved in some engagement activities. I know nearly 1,000 people responding to a co-creation exercise that we've been going on. I've had a conversation with people where we've asked what's been going well and obviously what else do we need to do more of. And these are some of the messages that have been coming back from colleagues and from patients and carers and partners as we've been working through. And that will lead to us recasting our journey to change in the spring, to give us another kind of 5-year runway really for our next steps as we move forward there. Some helpful things there that people have noted, which I'm sure you've read in the pack. So before I hand over to the chairman again, just to, I guess, pick up on some of the things that people said that we need to do to think more about in the next phase. I think there's a reflection in some of the commentary that we've received back that actually we spent a lot of time on culture and on engagement and trying to re-embed those values and identifying the way and the how that we're going to embed the improvements. What we need to do now is to spend more time really looking more fundamentally at the clinical models. The transformation work that I've mentioned, I think, leads us very nicely into a sense of framing that around promoting resilience, earlier interventions, and being really clear about the effectiveness of the treatment and support that we offer in the community in particular. There are also opportunities to look at the quality of the inpatient services that we offer, and we're part of the National Inpatient Quality Transformation programme and working very closely with a GIRF lead around that as we work through. There's issues been raised about fostering an open and collaborative culture. This is building on some of the work that we've done. Mentioned obviously that we've been doing some significant work on duty of candour and those sorts of areas. But when we think about some of the really deep work that we've done in terms of co-creation and listening to the voice of patients and trying to reflect patient and care experience in what we do, more of this. We've got some significant shifts in key areas of policy, like things like the removal of the care programme approach and the shift to a more personalised care planning way. And we've got the opportunity to reflect on some of these messages there. Analog to digital clearly is going to be something for us all. This exercise comes on the back of an upgrade, a major upgrade to our EPR, electronic patient record, which has been a bit of a bumpy ride, but I think we're in much better shape than we were as we move forward. There's obviously opportunities for us now to think about how we optimise and get the benefits that we set out in the case for that there. There's also an increasing emphasis for us on clinical outcomes, using some of the national frameworks around that and including dialogue, which is a key patient experience measure that will be embedded in our ways of working here. Prioritisation of resources, clearly thinking about financial sustainability, how we face some of the really difficult decisions that we're all going to make, I think is also a key message that's come back. And in terms of compassionate and patient-centred care, I've said a little bit about this here, about the patient-centredness of what we do. We continue to approach what we do really with as much humility as we can, you know, thinking about that partnership between patients and carers and professionals as we work through, and also with other parties like the voluntary and community sector, thinking about how we can really be more holistic in the way that we provide and deliver our care. I'm going to hand back to Dave now.
Thanks, Brent. 2 final slides from me, if I may. Sam touched on issues that are on our radar. I think when I joined the Trust in late 2022, we had the benefit of the intensive support team that were in, offering a really expert and really incisive critique into the Trust. And one of their takeaway phrases was that we weren't always very good at seeing the wood for the trees. And I think, as Brent's touched on already, in terms of the plan on the page, we have made progress in getting better at seeing the wood for the trees and at owning our problems. This slide summarises, if you were to look at our board papers and look at our board assurance framework, which drives our board agenda and drives what we look at, you would see these issues on this slide replicated in our board assurance framework, in our assessment of where we aspire to be in terms of a target risk score, where our actual risk score is, and the mitigations that we have in place and whether they are delivering. I touch on 2 of them briefly. Patient care experience, I think, is obviously central for any NHS organisation, and particularly for one like ours. And it was one of the particular attractions that made me so pleased when I was appointed chair, that this trust has committed in peer support workers in a really very tangible and meaningful way. Peer support workers on each ward, with an aspiration to have them on each community team, with a professional leadership reporting up to a director of therapies, which is a board level position. I don't think that is necessarily something that you see replicated throughout the sector yet. So that very real desire to involve and hear from the patient care experience. And the other one I touch on is autism and ADHD, and our Council of Governors had a role with the Task and Finish group over 12 months to help us define what our autism strategy was and what they felt. Many of our public governors have experience of autism, or are carers for people with autism, and their input into that and their strategic drive for the Trust was really, really valuable in that context. But that just gives you a sense of what's on our radar, as it were. And then last slide, in terms of our future, Brent's touched on a refresh of our journey to change for the next 5-year view. Us working very closely with colleagues in CNTW and the ICB more generally, in order that we look at our services and how we work together. And then that working in partnership with the voluntary sector, with local authority colleagues, particularly around social care, the relevance of social housing. We were with the Police and Crime Commissioner in Tees Valley last week, that sense of trying to make this a much more joined up offer in terms of what mental health has to input to those health inequalities for the whole of the North East. So I think that concludes our run through. I'm really grateful for your time. I'd underline, I hope, the message about grip and control. Very happy to respond to any comments or questions you may have.
Thank you. So comments and questions, please. Sarah Malik, who's one of our GP partner members.
Hello, thank you, Brent and David, for that presentation. Obviously, we know that people and culture are the mainstay of any organisation in health and social care services. And my question really was around the staff survey that you mentioned. I think I'd be keen to understand what the key themes coming out of the survey was, and also any cultural work or methodology that you've applied, taking into consideration EDI and inclusion groups.
Yeah, please go ahead and respond, Brent.
Yeah, thank you for the question about the staff survey. Can you hear me? Yeah. We obviously got the latest draft results through relatively recently. We've maintained our engagement levels at about the same place as they were last year. Last year we were the most improved mental health trust in our sector, in our group with PICA. And we attribute quite a bit of that really around the areas linked to what it feels like to obviously work in our organisation, because that's clearly what the staff experience is about. But areas like the ability for people to raise concerns, the ability for people to identify how they can develop their careers, and their ability to be supported when they're under pressure within their jobs. Where I would like to see more movement are on the key killer questions, around the would you recommend this as a place to work, and would you recommend this somewhere to receive your care for family and friends yourself? We're kind of in the kind of late 50s on those measures, which are really the key ones. I'd like to see more progress with those. I think for us, some of the key elements really that we've been focusing on has really been about behaviour, challenging behaviour and difficult behaviour within the organisation, really reinforcing the values, having lots of opportunities to reinforce that, to work with colleagues within groups and individually around what gets in the way of living the values as an employee within our trust and working things through. So I think there's a really strong connection with that. We've got a number of staff networks which are really thriving, and they've really provided us with a great opportunity to think about some of the experiences of people that have probably been less heard in our organisation, and given us a real clear sense of some of the steps that we need to take to get underneath some of those factors. Obviously, we live in an area where we experienced the race riots. Middlesbrough and Hartlepool obviously were front and centre alongside obviously other areas in the North East. And that gives us real pause for thought, listening to the experiences of colleagues that live in those communities and to experience those. We've immediately taken the step to sign up with Show Racism the Red Card and take steps to demonstrate that we're an anti-racist organisation and work forward on that basis. So a number of key steps with that regard.
Thank you. I'm just trying to get in a few more questions.
No, very briefly. The other thing I'd highlight is the upstander, not bystander training that we're offering to board members. And I think that talks to the wider cultural point that the behaviours necessary to be an upstander, not a bystander, aren't just about race, whatever. It's a cultural change that the whole organisation will benefit from. Thank you.
John Rush, Non-Executive Director based in Cumbria.
Yeah, thank you very much for the presentation. And there's one's a comment and the other one is a bit more of a question. Is very interested to hear your very powerful, how should I say, working with the VCSE sector, and obviously you're linked into Healthwatch as well there about so those linkages are really important, and actually for you to articulate them in that way and explain them, I think was very enlightening. But I did write down your principles because they were the things that sort of caught me, and I'm going to read them out because I just want to make sure I got them right first. But yeah, no, don't worry. We do not refuse a referral. Patients are not discharged by services. We accept each other's assessments, and no wrong door to get help. Now, that creates a very wide way of dealing with the processing or the movement of individuals. How do those manifest themselves, and any examples of where it's positive? Sometimes it might be negative, where if you're abiding by those principles, the bar is so high that people will come into the service, and can the staff cope with all of that? I think the principles are great. I just want to work out what actually it means for you as an organisation.
Yeah. Well, I think it's a great question. It's an ongoing conversation, John. To be fair, they are the principles that we adopt and that we've signed up to within each of the partnerships. Because what we do is obviously we work with partners to set these pathways up and together. I think one of the key areas is about that trusted assessment, which is probably one of the most challenging aspects of getting to a point where we can, work on the basis of not having to repeat work for people and so on. For a long time, we've had self-referral as part of our services, and at the beginning of that, we were pretty concerned that we'd end up overwhelmed with demand, and we haven't seen that necessarily. We've seen obviously an increase alongside others. We haven't seen that opening of the gates and everyone piling through in that sense. And to take it to that next step really is it feels like a natural progression from there. The key principles around no wrong doors and not refusing or You know, turning people away is really one where we start from a principle of understanding that people come forward because there is a need, and it may not be a medical or clinical need. It could be a social issue, it could be isolation, it could be, you know, something financial, it could be anything to do with their employment, it could be a variety of things with their relationships and so on, and we're not necessarily the people to do that. So I think, speaking from the specialist provider end of that kind of relationship, I think there's an element of colleagues seeing the real benefit of working alongside the professionals that have actually got the key skill sets in these areas. The time, actually, is probably one of the other aspects that allow people to be supported in that way. If people do come forward to the service then for specialist input, we're in a bit better position to provide that therapeutic input. We're not necessarily doing a lot of that case holding and kind of other navigating, and we've got navigators as part of the process. So we can be really clear on where we add our value to that, and then we can hand them back to the hubs. And through that kind of more social aspect, there are opportunities for people to kind of come in and out easily of that world. So it's not all plain sailing, John. I will be absolutely honest with you, and you know, clearly there are conversations. There are obviously areas within our patch where provision isn't necessarily as comprehensive as other areas, so there's obviously gaps in some of the services that we can bring to bear. But I think they're good principles, and I think that, you know, they are taking us forward.
David Chandler, Chief Finance Officer.
Yeah, thank you, Chair. Thank you for the presentation. That was really helpful. And the certain bits in there I found really interesting, such as the early help model in Durham and Tees, which I found especially insightful. You did put up a useful slide on CQC, which sort of showed a general improvement, you know, a lot less ambers, more greens. So the ambers in the latest area were generally around the sort of safety metric. So I was just going to ask two questions, if that's okay. One would be, what's your latest sense of where you are today of CQC we're going to inspect today in those areas? Or if you give some assurance in terms of, you know, how much closer you are now to green in those areas, if you can. And then the second one would be, we're all aware of the financial constraints in next financial year, the challenges we need to make in terms of difficult decisions and the like. So I'm just wondering what reassurance you can give to maybe the board and the public in terms of how you would look to do that, but without putting safety at risk. That's okay.
Thank you. Yeah, thanks, Dave, for those questions. I think in terms of the CQC and our sort of self-assessment of where we are today, we would obviously want to see some progress in turning some of those ambers into greens. If you recall, as I went through the presentation, I've quite quickly mentioned that the main reasons, if you like, for, and I'm looking over here, for perhaps to be kept right for previous role, the main reasons really around those safe areas were to do with staffing levels, caseloads, as well as an issue about a backlog of serious incidents, as they were then, that we've worked through. We have completed that backlog, and we're obviously implementing the PSERF framework, and we've got into a much better place with our learning, our organisational learning, and moving things through. From a staffing perspective, I think we're in reasonably positive shape. We still have some teams with quite high caseloads. From a vacancy perspective, it's about 4% overall. So we do have some areas of variation across the trust, which clearly we're working to sort of level out. One of the key areas for us is around medical staffing, where we still have about a 22% vacancy rate there. And obviously you have to be shored up. It leads into your next question about finance. We obviously have a reliance then in terms of locum grade doctors, locum doctors, agency doctors, to shore that up. We've got quite a comprehensive international recruitment programme underway. We actually had some success from local recruitment as well, so we can see some progress there. So I'm going to fudge the question by saying I would like to see some progress. I would expect to see some progress in terms of our self-assessment against that grid going forward, but I wouldn't like to put my money on exactly where that would be at this stage. In terms of the financial constraints of the financial climate, then, you know, like other organisations, we are having a really deep look at financial sustainability, understanding our underlying issues, and thinking about how we can build on quite a sort of successful track record of delivering our targets. I think, you know, we've done relatively well over the years in terms of sustaining our position, but like others, we do have underlying pressures where we're going to need to transform our way through. That's some of the things that we've talked about today will contribute to that. You know, that will help us to have conversations about the estate, potential benefits of digital and AI as part of that. So some significant shifts that we need to make. We've got a big event happening on Friday, on Monday, where we'll be getting into this year's plan and working things through, and I don't expect that we've come through with a strong position.
Thank you. Go ahead, David. Yeah.
Thank you for me. Just two brief points. I mean, on the quality point that you make, David, Quality Committee welcomed colleagues from the ICB that I think sit and watch us in real time, go through our governance on quality, and that has a real focus on particularly the safety domain and how we're moving that on. And Brent referenced the recent niche report, which I think is another element of assurance, independent critique of what we're doing. We are absolutely clear, we are not complacent, we are still a requires improvement trust. That's what CQC said, and that's what our marking is. But as Brent said, that sense of, a relentless pursuit. In terms of the money, I mean, our out-of-area placements was something that NHS Confederation noted last week on a visit that they came to look at. And whilst primarily we're bearing down on that because it's the right thing for patients and it improves patient experience, as you will well appreciate, there is a knock-on financial consequence of that as well. So we're trying to never trade off quality and money. We're trying to do both. And for the avoidance of doubt, the board has explicitly said in public it will never trade quality for money.
Thank you very much. John Pearce, Local Authority Partner Member.
Thank you, Chair. Excellent presentation, thank you. And I know, sort of working alongside your partnership for the last 5 years, it's really clear to see the level of progress that's been made. So I think that comes so clearly in the presentation. You just answered one of the questions I had around the SAFE and the workforce element of that. But I suppose the other dynamic to that is the demand, and you've referenced integrated services both in the future and also the opportunities now. So it'd be good to just get some reflections on how you think we may be able to take forward some of those integrated services to impact on that demand and some of the pressures elsewhere in the system.
Thank you. Yeah, I mean, what I would say that characterises demand is that we've seen significant demand around children's services, as you know, John, particularly around the neurodevelopmental assessments, about 300% since 2019, which clearly, is overwhelming to a large extent. I think what we've seen is a levelling back of sort of routine activity to probably 2019 levels. Post-pandemic, it went up a bit. It's come back down in terms of, I guess, the routine flow of things. But what we see is a shift in complexity and resourcing that's required then to support people and so on. So I think that what we were describing around the transformation approach, working alongside colleagues, thinking about early help, in terms of the children's pathway, we're doing some work, aren't we, in Durham, pilot that in concert to think about how we can bring together, the work that we do through early help CAMS and your own services to provide a more comprehensive service to people in an earlier position within their need, expression of need. The work that we're doing in schools, the mental health support teams in schools, I think is a real feather in our collective caps, and is really starting to get on top of some of the population level kind of issues around education and sort of psychoeducation and health education and health literacy around some of these issues, but also some of that earlier support to young people that are expressing sort of need and working things through, advice to other professionals to prevent them from referring the need to refer on to other services. So I think there are some really live examples, particularly in the world that we've been working in locally within Durham, but also elsewhere, where you can see where integration is starting to have an impact on our ability to get in front of some of the kind of the development of need and some of that complexity that we're seeing now. So I think it looks positive. I think it looks like there's a real potential there.
Thank you. The final question, Anne Fox, Interim Chief Nurse.
Thank you. Thank you for sharing the improvement journey. I can only begin to imagine how difficult it's been for the people you care for and their families and friends, but also for the staff. And I just wondered what was in place now that mightn't have been previously to support staff wellbeing and resilience to be able to continue this journey together, really.
Yeah, thanks, Anne. I mean, it's an ongoing challenge, I think, isn't it, in terms of maintaining people's motivation and morale. We're all under pressure across health and care. Obviously, in the context that we've been working on, there are obviously key issues there. I think it starts with some of the fundamentals that we talked about in terms of the direction and the values, and some of the work we've done around resetting what we're about and the purpose. People having a sense, really, they can identify with what we're trying to do and make a difference to thousands of people every day. We need to find a way for them to recognise that and to reflect on that and celebrate that as we work through. Obviously, as part of it, there are some clear kind of interventions and support mechanisms that we've put in place. We've got an employee psychological support service. Clearly, there are other routine support areas there. One of the areas that actually came out of the earlier CQC report was we weren't doing enough around things like clinical supervision. We're really getting on top of that now, because we think that's the kind of a really practical, routine way that we can really connect people to practical support on a day-to-day basis. So a number of key things from that perspective. You know, there's also a range of other things that are going on across the trust, like we've launched our 10K race. You know, so there are some trust-wide events and things that are happening, you know, our annual awards and those sorts of things. So a variety of different things right the way from the kind of core of what we're about, you know, and why people do the work, connecting people to that through some of those interventions and some of the ability for us to celebrate.
We've run a little bit over time, but I think that just reflects how much interest there's been in what you've described to us. But I think we'd like to thank you for coming today. I mean, it takes a lot of courage to talk openly about the problems that you had and that you've the way you've addressed them. And I think, as you've said a couple of times, you look to be driven by the values, and I think that's really shone through in the presentations that you've given. So thank you, and we look forward to hearing more on a future occasion. But in the meantime, thank you for everything you're doing, and thank you for accounting for it so clearly. Thank you.
Thanks for having us. Thanks.
Right, we're moving on now to item 16, which is the quality and safety work, quality improvement and patient safety work that's been done by the team on urgent and emergency care. Anne Fox and Neil O'Brien are down for this item, but I do know Sarah Dronsfield has been, the Director of Quality, has been heavily involved in this work. I'm not sure who's going to present. Anne. But before you start presenting, Anne, this is your last public meeting as Interim Director of Nursing, and I'd really like to thank you on behalf of the board for the exemplary way you've carried out that work as Interim Nurse Director.
Thank you, Chair. As the board's already heard of the challenges that we've had in urgent and emergency care across the system, not just in our area, but regionally and nationally, it was necessary for us to have a mechanism to be able to monitor quality and safety during these challenging times. So, as you mentioned, Sarah Dronsfield, our Director of Quality, is here because, along with members of the quality team, Sarah led the development of a framework for us to be able to monitor quality and safety. That was done in conjunction with NHS England, with the APRR team, our Urgent Emergency Care Network and our providers. And Sarah's here to share that framework with us and also some of the early learning that we've deduced from that. So I'll hand over to Sarah.
Thank you, Anne. So in terms of the context, I think it's probably just worth just reflecting on some of the work that we've done before. So since July of last year, we've been monitoring incidents through the Learning from Patient Safety Event system, and that helped us identify themes and trends across the system. And from that, we developed a weekly executive summary of incidents, and that was around key incidents that we felt needed escalation. And we also have developed a patient safety incident dashboard that allows us to look at a deeper dive of those incidents, look at numbers, pick out themes and trends, and start horizon scanning around some of our challenges. I think what that did do, though, was put us in a really good place to develop this work around urgent and emergency care. And through that joint work with our system coordination team and our quality teams. In the middle of November, we started to develop this work. What we do know from the Royal College of Emergency Medicine is that their national data tells us that people that stay for 12 hours in ED are at increased risk of harm and actually increased risk of mortality. So it's a really key focus that we need to be cited on, and it's been a national priority that's been identified for the winter period. So this is our process going from left to right as you look at it. And what you'll see on the left-hand side is where there's sustained pressures, we can do a deep dive of the incident so we have access to the live system. And where there's no incidents, we'll just continue to monitor that. Where there's ambulance handover delays of over 3 hours, we'll review the after-action reports that come in via the truss. If we're assured, we monitor. If we're not assured, we go into the right-hand side of the pathway. And that's where we've got sustained ED pressures, evidence of incidents, excess weights, and the handover delays. Through that, we'll do a deeper dive of assurance work with the trusts. So for lower level risks, we will write to the trust and ask for assurance around key pieces of work. Where there's more significant harms that have been identified, we may instigate a quality assurance review visit and escalate those serious concerns to the executive team in line with our usual process. But one of the key things I think we need to think about is some of the themes that have come up, and these are similar themes to what are recognised nationally. One of the things that we've been doing through that work with the system coordination team is that we do identify that not all patients that stay in ED for 12 hours are being reported as incidents. And we saw that where through our daily information on radar, we identified a patient in excess of 12 hours in ED that wasn't reported as an incident. Equally, we had an incident of a patient staying over 12 hours in an ED department that wasn't reported through radar. So actually, it's really important that that joint working's happening. And we do know that people are exposed to risks. What we are encouraging trusts to do is any patients that stay over 12 hours that comes through as an incident. But some of the themes that are coming through are again aligned to the national data. So treatment delays, privacy and dignity, particularly when people are cared for in escalation spaces. There is some challenges around management of deterioration. There's lack of treatment in ED departments before transfer to wards. Ambulance delays are impacting on some risk to patients at home. There's significant capacity issues within the department. There's challenges around flow out of the department because of challenging discharge processes. There's been a high acuity of patients, infection as we touched on earlier, and staffing has all had an impact on some of those themes that have come through. In terms of some of the things that we've done to identify and share that learning, we do that through our weekly report. We shared it in the system with the chief nurses through our Urgent and Emergency Care Network Strategic Board. We will be developing a report around our summary of key themes and trends around incidents, and we have just set up, as of last week, a community of practice with trusts, with key safety people from organisations so that we can share good practice and learning. And some of the things we talked about last week was around safety in escalation spaces and how people monitor that through things like intentional rounding, where there's regular checks, including looking at privacy, dignity and checking for deterioration. And this week, some of the focus has been around cohorting as well, around some of those challenges. What we're really keen is that we encourage our trusts to learn from each other. The Royal College of Nursing produced a report just a few weeks ago around some of the psychological impact I think it's been having on nursing staff. And that's played out through that meeting as well. So, you know, staff have touched on actually it makes a big difference to how they feel about how they can care for people. So again, we've touched on how do we support people from a psychological well-being point of view? What good things can we learn from each other? What would we want to replicate across the system? I think touching on some of the points earlier around escalation spaces, there's a real inconsistency around how organisations are recording that. Some report that as through the System Coordination Centre and through the reporting on radar. Some do it through incidents. I think we're just working between the two teams now just to get a consistency so that when we're working with organisations, we have a common understanding of what's going on. I think just some of the other things we've been asked to share our approach with NHS England and the other ICBs in Yorkshire and Humber. We've been approached by a couple of trusts in Yorkshire and Humber and the other ICBs. One of the ICBs wants to implement the process in its entirety, and it's been seen as an exemplar of good practice. So I'm happy to take any questions.
Thank you very much, Sarah. Questions, comments? John Rush.
Just a quick one. How many are you talking about? I know it mentions on the report that you've done it twice in December. Yeah. What's the kind of volume and what's the work involved?
So we've aligned some of the members of the quality team to look at the incidents. So actually, I think because we've got 2 or 3 staff aligned every day to look at the system and be part of the meetings, it probably takes half of their day to look at the system and keep an eye on it. And because we're doing it regularly, it's actually a much quicker process. And because we've developed those skills, it's been easier for them. So actually, at the moment, it's really manageable. And I think, in terms of the assurance process, I think, that's been reasonable as well.
Okay. Anne Fox.
Thank you. I think for me, it's obviously a process, so you're obviously working through something, but we didn't want it to be a tick box exercise, and we didn't want to add to the assurance and reporting pressures that our providers already had. We wanted it to add value, and I think the work that it's starting to lead into now with the community of practice, the sharing of the learning, and our organisations being able to facilitate learning from each other, I think is what part of its strength is. And the fact that we've absolutely got quality and safety as a key feature throughout of all of our arrangements now. That may have been sporadic in the past when it was needed, rather than it being a consistent approach. So, and it has been, I have to say, received positively.
Sir Pally Hungin.
Just for information and to reinforce what Sarah has said, I've just checked the statistics. I can see I carry the BMJ with me everywhere. Patients who spend more than 12 hours in A&E departments are twice as likely to die within 30 days. That is a very scary statistic. It's produced by the College of Emergency Medicine. It just shows what we must aspire to. This 12-hour block is really crucial.
Can I just ask just a more granular question? Having looked at some of the incidents as they've come through this new system, it's clear that in the pressures in the A&E departments and the fast-moving pace of work there, that patients who are waiting in the department or in corridors are not getting the regular observations that they need to monitor whether they're deteriorating or not. And if I'm right, is there not a technological solution to this? Can some device not be attached to them, which would then alert a central desk in the A&E department and someone could intervene? It seems to me a very, very basic deficit, which happens as you know, on the wards when you get acutely ill deteriorating patients that aren't recognised. It's because either their observations are not being taken or abnormal observations are not being acted upon.
I think what I would add to that is, yes, I think it's definitely something that should be explored. But what I would say is the incidents that we've seen, which are really quite small in number, although we wouldn't want anyone, if we compare to the proportion of patients in temporary escalation spaces or corridors with teams who are receiving the care, we've got to make sure that we're not just focusing on those people. However, I do think from a technology perspective, I do wonder if there is something that we could do, and that's something that we could consider as part of our winter plans going forward. But I just think to remember that we're talking about small numbers where the care hasn't been what those teams or what ourselves would want there to be. But certainly I think in the scheme of things, it has been really challenging. There's definitely, I think, opportunities for learning and improvement, which I think this work will help us to unpack. Technology, I think, is definitely something that we need to consider.
I think it's a fair point that it's discouraging for the staff if you're always emphasising the negative rather than the positive. But the first WHO Global Patient Action objective is to have a mindset of looking for zero. So if you have a mindset where you won't tolerate one, then I think you're in the right place. And in my own view on healthcare infection, I think we're far, far too complacent on that. And we use rates to compare. We should be saying any case is unacceptable. And if you switch it round that way, ideally also, as you say, whilst praising the good work that's going on, I think that's probably the right balance. Other comments? Sarah?
Just to come in on the technology, I think in some organisations they are doing that. They have the ability to monitor people's news scores, for example, in escalation spaces. It's part of their electronic system, so they've got visibility. But we do know that some organisations have more challenges around estates and that can be more difficult. So there is things that can be done, including having portable call bells as well, so that people can do that. So I think the idea of the community of practice where we can share some of that learning really gives us that great opportunity to take those things forward.
A sort of superficial, well, not superficial, a less clinical point. I can remember in the earlier phase when we were working on reducing in the early 2000s on reducing the waiting time in A&E, there was a lot of talk with different quality projects, and we talked to the Formula One team, and the very first thing they said was, why haven't you got a stopwatch or a clock on that trolley? You know, how you should have them, and they should be turning from green to amber to red, and then you should be acting. And it was such a simple thing. We didn't. The hospitals didn't do it, of course, because you send out a suggestion, and there's only a few people that want to do it. But so if you had the clock measuring the waiting time and the monitoring, looking at the respiratory, blood pressure, and all the other things, you might start to get a little bit better. I don't know. Who's next? Rajesh.
Thanks, Sarah. First question, which I assume the answer is yes, is I suppose you also look at people who are waiting in emergency departments for mental health reasons, and some of those conversations might be with other providers in the wider system and also in the community. So I assume that's a yes.
It is a yes, yes.
Just the other question was with regards to, I mean, emergency departments are under significant pressure, and sometimes what they're facing is what actually is not going very well effectively in their local community. And is there any opportunity through the new system, which you're observing all the incidents and so on, to also focus on some people who probably visit emergency departments very frequently because their needs are not effectively met? And I know that most acute hospitals, along with some of their local partners, try to do work around them. But has the ICB got a view as to how they might influence something at a place level?
So I may let others come in on that, but I do know from working with Jacqueline's team, I think that's something that we're really keen to do post this winter period, that really quick after action kind of review and learning, just to see what opportunities we've got. We might find that there's pockets in places that we need to do different things I think that's a really important thing. So next year we go into a different place, ready for winter.
Sam?
Yeah, I think that's a really great question, Rajesh, actually, because I think just in terms of our role, inevitably, and I think particularly when we've looked at this period as well, just in terms of, we heard earlier that attendances haven't gone over this period, but we do know that the number of older people, kind of frailty, and so actually really looking at that sort of population health approach to see what we can do to prevent. My comment was Chair, was just going to be focused around the learning and the improvement, because, and it links a bit to your comments as well, Chair, because I think at some point in time, we used to operate a system where we didn't need this, because we were hitting the standard, what it was in terms of the 4-hour assessment, 12-hour decision to admit was a rare event, with a few exceptions. But on the whole, actually, we had a system where we didn't have to put an insurance process in place like this, because we've got a system that's under duress at the moment. And I think, so the learning you're picking up in terms of the staff experience, I think, is fundamental. And I think there's a lot of talk also around moral injury in terms of the way the system's designed. But also something about how we equip and reinvigorate the skills around productivity, efficiency, and do the work. I think, Rajesh, your question gets to the heart of, which is where can we prevent attendances so that we can move out of the situation. Having said all of that, we did say that quality and safety was going to be the key priority this winter. We've put this process in place so that we have got a system level of oversight, and I would hope from a public confidence perspective, I think particularly when we've seen the pressures all over the country and ambulance days, and actually never mind the stopwatch, Chair, I think you've only got to have your loved one sat in a trolley in a corridor waiting to get into a bay or into a bed, or in the back of an ambulance waiting to get into the treatment area, to know the real impact this has. And sadly, that is a feature to some extent of our system as we have it today. And I think unless we do get upstream, we're not going to change this. So the learning and improvement, key. But also the redesign of the system. I wouldn't want us to think, because we've put this in place, it's job done. Actually, it helps us mitigate the very real risks that we've got, but unless we change the system, we're going to have to do more of this. And if we're doing more of this, which is doing the checking, we've got less capacity to do the changing. So we have to be able to strike that balance somewhere along the line.
Thank you. Levi Buckley.
Thank you. My points have already been made.
Ken Bremner.
Liam, I want to come back to your comments about care and oversight of patients in congested ED departments, because I think it's right. It is unfair to say, in my view, that these patients do not get any care. I think the comments I've picked up myself now is in both my ED departments, so we class Friday for a whole day, and they are congested, but we've got a lot of patients who are in the wrong place and they're not getting their time and their care in a timely manner. It's wrong to say they're not getting any care. They are getting it, but it's not as quick as we'd want, and it's not in the right place. So I do want to just correct you a little bit on that. And I agree with Sam and Question Away. Until we solve the issue around decongesting those departments, we'll be having the same conversation this time in 12 months. And that's sorting out what comes in the front door and also what goes out the back door. Now, I've seen, if I look at our community-ready patients in both my main hospitals, Sunderland South Tyneside, 2 or 3 years ago, if we had 50 to 60 community-ready patients, I know the definitions have changed somewhat, we'd be appalled. Now that number's up to 150. And South Tyneside's got about another 50 as well. So I've got effectively 200 of my beds blocked. I've only got 1,100 in total with community-ready patients. So not only are we not controlling what's coming in the front door, and I agree that we've got to tackle that, we've also got to do something about helping people out of ED departments into beds or back into the community or their own homes. We'll be having the same conversation unless we tackle that. My ED department, both of them, functioned really well during COVID. Why was that? Because they had 50% less activity going through there than we normally would have. The flow in our hospitals worked perfectly. Those are some of the lessons I think we've got to learn. So there are solutions there. They're difficult, but let's focus on the stuff that's really going to make a difference to big numbers, not small incremental change.
Thank you, Ken. Eileen Kaner.
Yeah, it's a point maybe just drawing together some of the contributions. I had the experience of embedding my team 24/7 in emergency departments across our region. And at the weekends, and certainly at certain times of the day, 70% of those presentations are alcohol and substance use related. So there are people presenting there for alcohol and substance use problems who'd be better dealt with elsewhere. And I think it just gives you a specific evidential sort of contribution around Ken's point about, these are very busy places and there's people who'd be better dealt with somewhere, their needs would be better dealt with somewhere else.
We've covered all the questions. I'm a bit worried we're running quite late now, but another very, very interesting presentation and discussion. So thank you, Anne and Sarah, for that piece of work, and we look forward to hearing more progress on it. Now it's another important item, and I think, Jacqueline, you've got a presentation to start us. You might possibly think of moving, not showing all of the 20 slides, but if you could orientate us to this. This is really, this item 17, is a new set of tools and guidance that the Centre has sent us to further strengthen the work that ICBs around the country and FTs around the country are doing on elective care and carrying on the recovery after COVID. So, Jacqueline, if you can tell me what's being asked of us and how different it is from what we're doing at the moment.
Thank you, Chair. I certainly can. I did share the slides in advance, so recognising that we're a little bit short for time and people may have questions, I think I'll just draw some headlines out and then I can always take further questions. It's very much in the way of a briefing, isn't it? But there may be questions. So the new Reforming Elective Care for Patients plan was published on the 6th of January, and it's very much a kind of, it builds on previous plans we've had around elective recovery in the last 5 years. So I would say it's a kind of continuation of the sorts of things we've seen previously. And I suppose that the key things that are notably different is there are some very ambitious targets for improved performance against the well-established constitutional standard. And also there is just a few new areas of emphasis that I'll draw out. So I thought I'd just start by reminding the board about the constitutional standard, because we've been very much focusing on long waiters in the last few years. But this is very much, it's been described as a pivot or a return to focusing on waiting times for everybody, I guess, rather than just on the very longest waits, the over 1 year, or if you recall, the over 2 years we were focusing on for a long time. So that the standard is that at any given month end, no more than 92% of people on the active referral to treatment waiting list, sometimes referred to as the patient tracking list, the PTL, should be waiting more than 18 weeks. And that's a measure of whether you're getting patients' pathways completed. That's from the point they're referred by the GP to the point that either they receive their treatment or indeed they get discharged following a consultation, that should occur within 18 weeks. And nationally, at the moment, that across England, the performance is about 60%. And here in North East and North Cumbria, we're at 69%. And we're often the first. Just last month, we were second out of 42 ICBs in terms of where we are against that 92% metric. But let's not kid ourselves. It's still a very long way to go to get from 69% to 92%. The paper that was published suggests that in order to sustainably deliver that 92%, we need to reduce the overall England waiting list that stands at 6.3 million. It's actually about 7.2 million pathways, but 6.3 unique people, 6.3 unique different people by about a third. And I would imagine that we are in a pretty similar position. We heard earlier, didn't we, that our current waiting list is standing at about 350,000 pathways. So a lot to go there. And the aim is that we'll get to that by March 2029. So just over 4 years. Although there's absolutely clearly in the paper an expectation that the better performing systems will get there faster. And we're expecting a follow-up paper entitled Further Faster to land with us in the next few weeks. And the paper signals that 20 providers, not systems, who are amongst the best performing, I think many of whom, I think 4 or 5 of which are in our patch, will be asked to make a plan to get back to 92% quicker, perhaps within 2 years rather than 4, and maybe able to access some additional income to do so. So that's just a quick overview. I mean, in terms of what's in the paper, it's in 4 pillars, and these are they: empower, reform, deliver and align. I'll just say a little bit about each, if I may, very briefly. So the eye-catching elements of empower are really around putting more information and ability to guide and initiate next steps in their pathway in the hands of patients, not solely but principally through the use of the NHS app. Might interest the board to know that there are 36 million NHS app users in England, so really significant, thought to be around 3/4 of the adult population, but actual functionality that's available to patients on the app varies quite significantly. Graham and I were having a conversation about this just the other day, and I have seen that 90% of our GP practices do offer the ability to view appointments on the app. We're just doing some due diligence to check where we are with our 8 acute provider trusts, but there are expectations in the plan that 85% of acute trusts will be able to allow patients to view their appointments on the NHS app by the end of March coming, and I suspect we'll get more detail about expected functionality of the app. Of course, that you can not only view, but in some cases book appointments, change appointments, view letters, view results. So it has a lot of functionality, as well as access a lot of health promotion and health advice. So a real focus on building on the app, but also a focus on addressing health inequalities within access and outcomes in relation to elective care. In terms of reforming delivery, a couple of the key pillars there are around a new agreement with the independent sector to make sure that we're using all of that capacity as part of the solution. And there's a particular focus on some of the most challenged specialties, ENT and gynecology are called out. Also, a focused use of the new community diagnostic centres. The board, I think, has been made aware previously, but just to say we've got some really significant community diagnostic centre developments. In our patch, we opened a new one in the Metro Centre that serves the Newcastle and Gateshead population back in October, and I think we're just weeks away from the Teesside community diagnostic centre that's going to be on Stockton Waterfront opening up, as well as a number of others across the patch. And then there's also a focus on surgical hubs. Again, we're pretty well provided for in terms of surgical hubs. I don't think we have any new ones within the 17, and actually when you look at the detail, most of those had already been green lighted and were in the process of being built. But as I touched briefly on the programme that we've got locally, there's certainly opportunity around using the surgical hubs that we do have more effectively and more productively to maximise the way that they, the volume of patients that they're able to treat. There's also a focus on what's described as delivering care in the right place, and there's a number of facets to this. Notable inclusions are that for the first time GPs will be able to receive a payment for utilising advice and guidance. We're pretty confident that advice and guidance is well embedded in our systems. We've got high levels of utilisation. There's a suggestion there that we'll do 120 advice and guidance requests across North East and North Cumbria in the year we're currently in. But there are opportunities to optimise that, certainly in terms of the how quickly specialties respond, and thinking about how that works optimally in terms of addressing the regular concerns that GPs raise. There's mention in the plan around the use of AI. I think we've talked about this briefly in the presentation previously at board. There are potentially opportunities to streamline pathways by using AI, particularly when people have had diagnostic tests done and they're waiting for results to be reviewed and acted upon. So we look forward to opportunities around that, and also a continued focus on patient-initiated follow-up. And this has significant application, particularly more in our medical specialties where we have patients who may be in contact for a service with many years but might not be well served by routine follow-up. And the last pillar is around aligning funding, performance and oversight. I mean, I think I would say that we have pretty strong oversight and focus on these standards already, notwithstanding that pivot back to the 92% target. And the one thing I want to draw out here, Chair, is the real challenge in the context of the financial position that we find ourselves in. We do know that in previous epochs, when we've had a big drive on getting back to delivering the 18-week standard increasing level of activity has been a big part of the solution. I don't say it's the only opportunity, but it's a major one. And since we'll no longer have a kind of open-ended access to the elective recovery fund in order to be able to maximise additional activity as a major driver to get that waiting list down by a third, I think it will be a significant challenge for us to really focus on redesigning pathways, being more productive, and thinking about very much focusing on the outpatient end of the waiting list to really deliver that 92%. And I think we'll find it challenging to particularly address the admitted or inpatient waits without access to significant additional activity. So that'll be an interesting one to watch. There may, of course, as I mentioned earlier, be opportunity to access some income through the Further Faster programme. The remaining slides are just a quick look, Chair, at our own data, which I'll just whiz through very quickly. I mean, just in very short order, we continue to exceed the England average, as I've already mentioned, in terms of the 18-week performance, and also we're significantly below the percentage of people waiting over a year. And as you can see there, we saw some significant improvement. England is looking like it's starting to catch us up a bit there. This one just shows you how, if you like, our total waiting list, whilst it's grown, it hasn't grown at the same percentage rate compared to the population of England. So we're actually, our proportion of the total English waiting list is shrinking, which is a good sign, isn't it? Because we want a smaller waiting list as possible. But we are still significant at 4.7%, so we are a bit of a kind of weather maker for the overall national position. I already shared this. You can see here, this is us at number 2 in the November benchmark compared to other ICBs for the percentage of patients waiting below 18 weeks, and at number 3 for the percentage waiting over 52. And this is just to give you can't see this, you might be able to see it better on your laptop. There is a 25-point percentage difference in the performance between our best performing trust and our worst performing trust. So there obviously are some real opportunities for improvement in a number of our trusts, but some opportunity to learn and improve. And this is a similar graph for our over 52-week performance. Very briefly then, because I know we're tight for time, in collaboration with our provider Collaborative, who lead our strategic elective programme, we pulled together some slides just to give you a sense of how the new plan maps to our current approach. We're obviously going to be doing a very detailed piece of work to take all of the richness in the elective reform plan and make sure that we're responding to it. But in headline terms, when we recast our own elective care improvement programme just over 12 months ago, we focused in on these 3 areas: performance, productivity and pathways. So essentially we're kind of quite well set up to map in the new elective reform plan into the work streams that we've already got. I've shared the governance, which I'll go over. And then at the back here is just some information about the achievements that we've delivered in this programme over the last 12 months. Still plenty more to do, and I think in particular, if you've had a chance to look at the slides, you'll see that whilst we had a very active mutual aid group, and that's been quite successful, over 600 patients changing which hospital they're treated in order to access care earlier, that's not necessarily an area we'd want to have massive focus on going forward, because people want to be treated in a timely manner in their local hospital for the most part, don't they? But what that work has done is it's created great working relationships between our providers, which is a good basis for collaboration and learning, but also it's given us some areas where we're going to target earlier intervention in terms of trying to balance capacity and demand by encouraging people to refer in the first place to those hospitals that have the best opportunity to treat in a timely manner. And we've just recently done a real detailed piece of work on our outpatient transformation programme to make sure that's set up to respond to the challenges and opportunities that are outlined, both in the Get Right Place, Right Time pathway type work that's led by Professor Tim Briggs, who we work with very closely, but also that productivity challenge. And one of our COOs is also leading a theatre optimisation and productivity programme, and that's going to pick up that work around optimisation of the hubs. So that's a kind of very whistle-stop tour through a lot of slides, but I'm happy to take any questions. Thanks very much, Chair.
Thank you very much, Jacqueline. It's very clear. Comments and questions then? Graham.
Thank you, Chairman. Just to supplement Jacqueline's update, in terms of our regional population, we've got about 55% of our adult population 13 years and older using the NHS app, so that's a good statistic, but there's still further to go. Within our provider organisations that are using patient engagement platforms integrated to the NHS app, it's roughly about 75% at the moment, but growing. There is one trust that has a patient engagement capability that isn't interoperable, so we've got a bit of work to do with that, but that's probably a national issue rather than a local issue, but we are making progress. Thank you.
Do we, just before David comes in, do we know what the realities of the use of the choice option are? I mean, are a lot of people doing it? This is the existing rule, even before this, that over a certain length of time waiting, you're entitled to request a choice of other hospitals.
Yeah, so there's two sort of extant facets to the choice option. There's a sort of choose and book functionality at the beginning of the pathway, and we did some recent validation of that. I have to say the ability for GPs to give patients choose and book functionality has really reduced since COVID. Far fewer appointments are made available on choose and book across our patch. I think that's also the national picture than was the case prior to COVID, and that's largely because there are long waiting times. Trusts are putting kind of clinical validation and prioritisation processes in between receipt of a referral and booking it. But I think there's a big piece of work to do there around re-establishing choose and book. In terms of the second thing you mentioned, Liam, which is where if you've waited more than 40 weeks, there was a scheme to offer you an opportunity to be you were kind of proactively contacted and asked whether or not you would like to go to an alternate provider. We've had one tranche of that just about a year ago that was initiated by NHS England, and we had, from memory, I don't want to get this wrong, about 250 patients take up the opportunity to explore whether or not a clinically suitable alternative could be found for them. And in the event, we had quite a small number of patients actually move through that scheme. I'll have to check the number, Chair, but I think it was in the order of 50. For whatever reason, NHS England has paused that process and we haven't kept that going. So we only had a single tranche initiated, as I say, about a year ago.
Thank you. David.
Yeah, thank you, Chair. I'm just wondering, given the NHS England desire to go from analogue to digital, would you be encouraging everybody, all the public in the North East North Cumbria to be downloading that app? And then secondly, I know we talked about this in our forums, what reassurance could you give to people who, members of the public who would obviously find using the NHS app difficult for a variety of reasons? What assurance you could give them?
If I come in there, Chair, if that's okay. So I would absolutely be encouraging. We do know that there is a challenge that we call digital exclusion. This is a societal issue rather than just a healthcare issue. We are developing a strategy to try and approach some of that. Part of that solution is to offer devices that have been donated or repurposed and then offer those to the members of the public. And we've got some great examples in our maternity system where we can demonstrate that we're doing some of that. But that's not the ultimate answer. What we also need to demonstrate is where people cannot access digital services, that we've got a viable alternative, certainly for the short term.
Sam.
Thank you, Chair. I really welcome the plan. I think, certainly if you're sat on one of those waiting lists, this is exactly the type of plan that you want and the type of support. And I think it's going to be really interesting to see the sort of 10 or more straight test pathways as well, because that's certainly something the public have told us around actually, can we get straight into those diagnostics? And I think the hard work that's been undertaken, and Ken, thank you for your leadership on the diagnostic programme as well for the community diagnostic centres, is fantastic. The one thing I think it's important though for us to, I think, just acknowledge as a board is the conversation we had earlier today about the many thousands of children and young people sitting on our mental health waiting lists. We don't have an equivalent plan at the moment, and also there are only going to be a finite set of resources in order to meet the NHS priorities. This is a top priority, and therefore it will take a big chunk of the resource. And therefore the areas we've spoken about around left shift, hospital to community, sickness to prevention, this is why I think we are going to have to really think through the planning round this year. Obviously, this will form a key priority. It will need to be funded. We're going to have some difficult decisions to make in terms of what else is within our gift with the resources we've got available to deliver NHS services for the population of the North East and North Cumbria. And I think it's just important and incumbent on me as the accountable officer to really highlight that to the board, and also what are going to be some difficult decisions for us to make over the forthcoming weeks.
Thank you. Rajesh.
Yeah, thanks, Jacqueline. And I think, Sam, you picked up the first issue, which I was going to raise, that there's nothing we know about managing the elective weight in mental health. Having said that, I really like this approach of empower, reform, deliver, and align. So two things. One thing would be, if we have got some quick solutions on patient engagement or experience platforms, or whether it's anything AI works there, it might be useful to think about how we can also apply that to the mental health pathway quickly. The second thing would be with regards to community transformation, which eventually will deal with a lot of the elective weight. We often know what the outcomes are, but it might be good as an ICB to actually have these 4 principles as kind of our milestones to see how a particular system, a local system, is developing towards those outcomes. Because if we empower them, deliver and reform, what do we say, it also makes it easier for us to align funds. And the final point would be which I should have made a point before, while we're developing integrated neighbourhood teams and so on and so forth, and we've got community mental health hubs being developed, we really need to look about how they can be aligned together. If we do that, and sometimes it would just be about local initiatives and relationships, we will make a difference on elective and also on ED.
Thank you. I think we've finished another very interesting and important item. So thank you, Jacqueline, for preparing the presentation and taking us through it. We're now come to the questions from the public.
Thank
Claire.
you, Chairman. We've received 2 questions. Both are not related to the agenda today. One relates to GP services and patient satisfaction within the Tees Valley area, and another links to AI in the delivery of mental health services. We will draft a response and make sure they are available on our website.
Thank you. You don't need to talk about this today, you don't think? No. Right. Good. Well, I think we've concluded the meeting, and thank you very much, everybody, for your patience. It's been a long stretch right through the day with a short lunch break. So I hope you found it useful, and as ever, the door's open if you want to come back and talk to the executive team about any of the work that's going on. And I know that you're conscious of the time, and there's a lot of things that maybe you'd like to ask about or say, but you're being disciplined given the time limits for the agenda item. So if there are things, then don't hesitate to come in, especially if because I think we didn't have long enough on that discussion that started on quality improvement, but especially if you've got ideas there, which you think are obvious and we should be pursuing them, even though there's quite a lot happening already, then do pass them on. And if you've seen things somewhere else in the country or elsewhere in the world which you think works in a situation like this and we're not doing them, please bring those along as well. So thank you very much, everybody, and look forward to seeing you next time. It'll probably be a development event next, I think.